Thank you. I would also like to acknowledge Sandra Wong, Amy Charlebois, and Jennifer Harris, and Angela Varas-Budge for their hard work in putting this day together for us. And very importantly, I would like to recognize Andrew Brown from IT for his expertise in making this hybrid event possible. Thank you all so much. So as you can see, Andrew has the agenda pulled up. We have a very busy day, but hopefully informative day planned for you today. We have the breaks indicated, so just to review those for you, between 10:30 and 10:45, lunch between 12 and 12:30, and then an afternoon break between 4:15 and 4:30, and we'll be wrapping up by about 3:45, 4 o'clock. So I'm going to turn it over to Sandra now.
Thank you so much, Bonnie. Hi, everyone. So just a few other housekeeping items. Just want to let you know that all sessions today will be recorded and the recordings will be available on our website in a few short weeks. Additionally, the link to these video recordings will also be sent to all our registered participants. So keep an eye out for that. We'll also request that you hold your questions to the end of each presentation. For the virtual audience, we'll open up our chat and we'll have you and invite you to ask your questions there. Myself, I will be moderating the online virtual audience participants, your questions, and then Bonnie will be moderating all the in-person questions from our participants. And then lastly, we also have an evaluation survey that we really hope that you can provide us some feedback. I'll send the link and in the chat throughout our sessions today. Additionally, you can win some prizes upon completion of the survey. So make sure you enter your name as well as your contact information so that we can contact you for the prizes. All right, with all that said, I'll hand it back to Bonnie Quinlan.
Thanks so much, Sandra. Okay, so we'll just jump right into the day. And to start us off with the University of Ottawa Heart Institute's hub and spoke approach is Bonnie Bowes. So I'm just going to start by reading a little bit of a bio of Bonnie. She is our Vice President and Chief Nursing Officer of Quality, Risk, and Health Information. Bonnie obtained her undergraduate and Master of Nursing Science degrees in Australia at the University of Western Sydney and Charles Sturt University, and holds clinical specialty certifications in both critical care and cardiovascular nursing. Bonnie has extensive education and experience in hospital management, quality processes, performance measures, and enterprise risk management. Welcome, Bonnie.
I'll take off my mask. Good morning and welcome to the University of Ottawa Heart Institute, both in person and virtually. As an institution completely dedicated to the care of cardiac patients, we're lucky. We have a unique expertise and concentration of expertise in one building. That being said, we're not the only institution in our region that takes care of cardiac patients. In fact, every institution in our region takes care of cardiac patients, be them hospitals, long-term care facilities, or clinics. And that's why we're talking about the hub and spoke model. So the hub and spoke model is a model that disseminates information from a central tertiary institution out to a regional hubs and spokes. So the goal of that is the ability to leverage expertise and research from specialty services and provide the same standard in the community. The ability to adjust activities based on community needs or requests. It allows scalable and gradual expansion of services. It allows strong connections between the hubs and the spokes, enabling better transitional of care for our patients. And it reduces the need for hospital services through better prevention and follow-up care delivered in outpatient settings. The enablers of this, advances in technology, of course, less invasive procedures and growth in telehealth facilitate an integrated care model that serves patients closer to their homes in their communities. And close relationships with providers throughout the region are the key and the heart to any good hub and spoke model. So you see a graphic up here. This is our picture of what the hub and spoke model looks like. The hub in the middle is a tertiary node, so the tertiary care institution. There's community hubs, which are often hospitals, regional hospitals, and then spokes, which could be long-term care facilities or clinics in the community. Our Champlain landscape, we've been doing this for quite some time at the Heart Institute. Our tertiary cardiac services are invasive procedures, complex cardiac conditions, specialized intensive care services, and they're all provided centrally. So these are things that only the Heart Institute can provide. We also provide access to ongoing clinical and medical education, updates for the spokes that we provide centrally. New programs for cardiac services are developed at the Heart Institute as well. And we work with our regional spokes on implementing those. Spokes volunteer for programs, can request different programs and different supports for their initiatives from our contacts that we regularly communicate with. And the model includes both service delivery, so procedures that we do, and programs that we provide. These are the programs that we have in our hub and spoke model here at the Heart Institute. So telehome monitoring, automated calling, so IVR calling for heart failure, automated calling for acute coronary syndrome, and smoking cessation, remote echo, the STEMI program, pharmacoinvasive PCI program for STEMIs that happen outside of a 1-hour window from the Heart Institute. Our guidelines apply to practice programs for both heart failure and acute coronary syndrome, telerehab, smoking cessation, and coming soon, women's heart health program. This is a picture of our Champlain-Lynn region. The colors on the bottom all represent different programs that we provide here, and the wheels show which of the community hubs have what programs. So you can see that it's spread out across the region. This is a different graphic, but it really highlights the cardiovascular rehab program in its different forms and where it's spread out within our region. This is our framework for implementation, and there's a lot of words on this slide, so I won't talk about them all. But you can see it's a phased approach that involves working really closely with our community stakeholders. We do evaluations, we look at gaps, we work with the teams at the other hospitals to try to tailor the services that would fill those gaps. We do a blueprint, we make a plan, and then implement. So we help the regional program with their implementation, which also often involves us going out to their site and doing education. And then there's always evaluation at the end. So that's just a little overview of our hub and spoke model. You're going to learn a lot about our programs today. I hope you can bring some of that back, but also keep in mind that we are here if you think of something that would be useful for your program in the community, or you just need information or added education, please reach out and contact us. I think I'm waiting for the chat to do questions, so I will refer you to the chat. Sandra Wong, who's manning the chat, actually has lots of expertise in this area. She's the regional program educator for this hub and spoke model. So thank you.
Thank you so much, Bonnie. I'll invite you guys to ask any questions in the chat if you have any. Bonnie, maybe I can start us first. In your experience, what would you say are some barriers and facilitators in using this hub and spoke framework within the Champlain-Lynn region?
Thanks, Sandra. I should mention too, one of my jobs before my current job was the same job as Sandra. So I spent a lot of time going out to the regional hospitals, doing education, was the one who implemented the heart failure gap originally in the communities. What I found was originally our barriers were that we thought we could use ourselves as a test kitchen and then roll it out to the community, and it would just be exactly the same as we do it at the Heart Institute. But what we did realize is every institution has a unique culture, a unique structure, different resources, and that it really is more of a, not a we build it and we send it out. It really is a working together process. So one of the barriers is that every single institution is different, but we've adapted to that over time by not having a one size fits all program. So we do, as you know, Sandra will work really closely with the institutions and roll out something that works for them.
Thanks, Bonnie. I see we have a hand from Louise. Louise, do you want to ask your question through the chat? Or we can unmute you if you want to go ahead and ask your question as well.
I think we're having a problem with the mute button. It keeps on going on and off there.
All right.
Hi there. My question is, I'm a nurse who works on H3. How could we get information about what's available in the spokes out there to be able to better facilitate our patients that are coming in? Because I don't necessarily always have up-to-date current information to share with the patients as to what their services are. And how to better help connect them. What sort of resources would be available for us floor nurses to help them out better?
Good question. I can tell you first that each of the hospitals, if you're sending them back to a hospital, each of the hospitals in our Champlain-Lynn actually share our educational resources. So videos, books, that sort of thing, anything that we provide out to the patients, they also have access to. So it's there. As far as programs like telehome monitoring and IVR and rehab, I would encourage you to connect with Sandra and or Jennifer Harris, who has all the rehab programs, to find out which programs are available in that community and what you can refer them to. If you do refer them to rehab, rehab will direct them to that community resource as well. So that can happen after the fact as well. And for the other programs, it's great if you can connect with Sandra to pass that on to the patients.
Thank you. That's great information.
So maybe I'll let, if there's anything else, I'll let you put it in the chat. We'll be monitoring that throughout the day. And I think as you learn about the programs as the day goes on, probably more questions will come up. So thanks for listening and have a great day, everybody.
Thank you very much, Bonnie. That was excellent. Okay, so our next presentation is titled Enhanced Recovery After Surgery Guidelines, Clinical Applications. And we have quite a few presenters as part of this group: Dr. Mark Ruel, Amy Charlebois, Tammy Lafreniere, Kim Twyman, Joanne McNeil, and Emily Sawyer, Julie Emily Serrano, Julie Sawyer is presenting on behalf of Emily, who is away this week. So I'm just going to read a little bit about all these folks so you know them a little better before they get up here. So Dr. Mark Rowell is the division head of cardiac surgery at the Institute. He received his medical degree from the University of Ottawa in 1994 and his Royal College Specialist Certification in Cardiac Surgery in 2000. Dr. Rowell is a professor in the Department of Surgery, primary affiliation, and the Department of Cellular and Molecular Medicine, cross-appointed affiliation at the University of Ottawa. A seasoned heart surgeon, innovator, and researcher, Dr. Rowell served a leading role in the developing and promoting minimally invasive coronary bypass surgery worldwide. He has published 400 scientific papers and book chapters and is a recipient of numerous awards. Amy Charlebois. Amy is the advanced practice nurse for cardiac surgery, where she participates in patient education, care, and research. Amy received her Bachelor of Science in Nursing in 2007 from the University of Ottawa, then her Master's of Nursing Science, as well as a graduate certificate in nursing, specializing in clinical education in 2015 from Charles Sturt University in Australia. Amy has a passion for education, which she uses to deliver the best possible care for the Institute's cardiac patient population. As an advanced practice nurse in cardiac surgery, Amy provides clinical expertise in the field of education and cardiovascular nursing. Tammy Lafreniere. Tammy earned her degree in physiotherapy from the University of Ottawa in 2006. She has diverse clinical experience from private practice to hospital acute care, including intensive care units. Tammy currently works as the senior physiotherapist at the Institute, providing clinical and educational support to the inpatient and outpatient physiotherapy portfolio. She is a member of the heart transplant team at the Institute, putting forward the physiotherapy perspective to the interdisciplinary committee. For the last decade, she has demonstrated her commitment to the physiotherapy profession by assuming the role of clinical supervisor for several students, practice supervisor for residents, and an examiner for the Canadian Alliance of Physiotherapy Regulators. Kim Twyman. Kim has been a diabetes educator for 30+ years, working in the in and outpatient clinical setting, the community, and for a device industry. She currently is the advanced practice nurse for diabetes at the Institute and volunteers at the local and national level for Diabetes Canada and the Canadian Diabetes Educators section of Diabetes Canada. Kim has quite literally transformed the management of patients with diabetes within the Institute. I added that, by the way. Joanne McNeil. Joanne completed her Bachelor of Science degree in nutrition at St. Francis Xavier University, then went on to complete a Master of Science degree in business at Houston University in Bangor, Maine. She also taught a sports nutrition course at the University of Maine and Washington County College. Joanne has worked in the surgical intensive care unit, the coronary care unit, and the reference center for the past 7 years, where she has had the opportunity to participate in research initiatives, including the International Nutrition Survey. Emily Serrano. Emily is an advanced practice nurse in smoking cessation. She has 2 years of experience specializing in smoking cessation and 6 years of experience working in an acute care setting. In her current role, she provides clinical expertise to the Ottawa Model for Smoking Cessation and manages the Quit Smoking program at the Institute. Emily is currently completing her Master of Nursing at Charles Sturt University and has a special interest in clinical education. She was drawn to this specialty as she knows many people who have struggled to quit and saw the positive impact quitting smoking had on the individual as well as the healthcare system. So I'd like to welcome these amazing presenters at this time. Thank you.
Hi, everyone. Thanks so much, Madi, for that introduction, and thank you so much for this opportunity. Thanks for everybody signing on today. I hope you'll find our presentation helpful. So very first thing, what we're going to talk about today here is what is ERAS, which are the Enhanced Recovery Guidelines After Surgery. So here's just a list of our team. Bonnie just introduced everybody. And these are all the people that are going to be discussing ERAS for cardiac surgery here at the Heart Institute for you guys today. So what we're going to talk about first, we're just going to do our little intro, which we're doing right now. We're going to talk about what is ERAS. We're going to have a little message from Dr. Ruel, the Chief of Cardiac Surgery. Tammy's going to talk about physiotherapy in ERAS. We're going to talk about nutrition, smoking cessation, diabetes pre and post, surgical site infection in ERAS, and then we'll have a closing. So one of the big pillars for ERAS and for the Heart Institute really is teamwork. So we know that teamwork divides the task and multiplies the success. So we know the only way new programs and ERAS and these types of things can be successful is with teamwork. So the big thing is that it's not just the people presenting today, it's the whole group, our quality department, the nurses on the unit, the rehab team, the prehab team, you know, it's a whole group effort. So just a definition for you guys today. What is ERAS? So those are the Enhanced Recovery After Cardiac Surgery guidelines. So these are patient-centered, evidence-based, multidisciplinary team-developed pathways for a surgical specialty. So today, cardiac surgery and facility culture to reduce the patient's surgical stress response and optimize their physiological function and facilitate their recovery before and after surgery. So it provides, the ERAS guidelines really provide evidence-based protocols for perioperative care. They optimize patient outcomes, healthcare delivery efficiency, and cost saving. And they're based on the principle of best practices, standardized and consistent healthcare delivery. There's regular audits, team feedback, all with patient-centered focus. So of course, the main goals are to reduce complications and promote early return to normal activities. And of course, to have the best patient care possible. So just to give a little bit of a spot of where you can find these guidelines. So Engelman et al. Have this JAMA Surgery journal where you guys can find these published. There's many different components of ERAS throughout the journey of a patient going for cardiac surgery. So there are some preoperative components, intraoperative and postoperative. So we're going to talk not necessarily about everything today, but we're going to touch on some of these things throughout the patient's journey through the multidisciplinary team. So I would like to just take a moment to open up a message from the Chief of Cardiac Surgery, Dr. Marc Ruel. So I'd just like to say a big thank you to Dr. Rowell for that message. And from here, I'm just going to go ahead and introduce Tammy Lafreniere to talk about cardiac surgery and physiotherapy.
Thank you, Amy. Good day, everyone on site and remotely. My name is Tammy, and I'm the senior physiotherapist here at the Heart Institute. So I will be reviewing with you how we prepare and optimize our patient prior and post cardiac surgery from a physiotherapy perspective and how we achieve best outcome. One of the ERAS Society recommendation is about prehabilitation, which enables patients to withstand the stress of the surgery by improving their functional capacity. We're very fortunate that we can see our patient in our prehabilitation program, which can be done virtually by Zoom, but generally we see them on site one-to-one. So the physiotherapists conduct their assessment, and usually we recommend a light walking program. Of course, we emphasize for the patient not to exercise with any symptoms, which usually comes back to being more of an interval walking program that the patient can walk a few minutes, but also rest depending on their symptoms. We also instruct the patient how they should do to transfer after surgery. We review breathing exercise, and we usually give them some gentle strengthening exercise for their lower extremities, because we know that a muscle that is exercised regularly will be more efficient in the usage of oxygen, and we're hoping that the patient can save some energy that way after surgery. We also provide some education and support to patient and caregiver during our live webinar while you wait for cardiac surgery. And this is a great time for patient to ask specific question about their physical activity and mobility. Early mobilization following cardiac surgery is very important to improve outcome. It has a positive effect on patient physical capacity, but also psychological recovery. It can also prevent some possible complication, and we're always hoping to reduce the length of stay of patient. Our early mobilization clinical pathway is safe, feasible, and beneficial for patients. As much as possible, we try to get patient up the first day after surgery. So we often provide support with to patient by using some gait aids, rollator walkers, or high platform walker, just to give them a bit more support. While the patient, we get them up in the morning as specialized physiotherapists in cardiorespiratory. We take that opportunity to do a respiratory assessment. We review specific breathing exercise. We'll help them with manual techniques that's needed. And at a later time during the day, we'll come back to get them mobilizing. So we're always hoping to get them up for a walk. And on average, patient will walk from 30 to 32 meters on that first day. The second day, patients are usually encouraged to walk, of course, with the help of the staff, the nursing and physiotherapists. And we're hoping to achieve 60 to 90 meters on that second day. By the third day, usually patients are able to walk all around the ward, which is about 120 meters twice a day. And on the day 4, we're practicing stairs if patients have stairs at home, just to show them the right technique. We do have a fast track pathway for minimally invasive cardiac surgery patient, which they tend to progress a bit faster. So they will mobilize a bit faster. And as you can see on this slide, sometime on day 3 or day 4, they end up going home. Now we do send all cardiac surgery patient home with an individualized exercise program, which consists in a walking program and some gentle stretching exercise and breathing, of course. And we encourage them to follow that until they start cardiac rehab. Now, from my experience in the past, I feel a lot of patients were scared hearing that name. And I will quote Amy Winehouse, her song, you know, they wanted to make me go to rehab, but I said, no, no, no. But it is now different with our new process in cardiac rehab. We initiate that conversation right away with the patient. A few days after surgery, our physiotherapy team review all the benefits of cardiac rehab, and they discuss with patient and then place in the referral for patient to participate in the program. So now we have great feedback from our surgery team that when patient comes to their physician appointment, they're also looking forward for the cardiac rehab appointment. And when we talk about cardiac rehab, it's much more than just exercise. We educate and counsel patients, and we help them in their recovery. Of course, here we're talking about cardiac surgery patient with the ERAS guidelines, but we're also offering our program to patient with acute coronary syndrome or heart failure, and we really target our program to whatever patient needs. What our cardiac rehab program include is, first of all, a risk factor evaluation that includes some blood work. Patient can benefit of a medical assessment with one of our cardiac rehab physician as needed. Of course, exercise training, but also we have nutritional counseling with our registered dietitian. They can also benefit of our quit smoking program. We do stress management session with the social worker, and our psychologists can provide tools to patients to manage better their emotion, manage their anxiety, depression, and sleep problem. Our vocational therapist can also provide assistance for patients in returning back to work. And we also provide caregiver and patient, of course, some group education session. There are several benefits of cardiac rehab, of course, but I think one of the most significant one is certainly that it will help to decrease any risk of cardiovascular mortality by 25%. It can also decrease the rate of readmission after any cardiac event by 31%, which is amazing. Cardiac rehab really lays the groundwork to develop a healthier lifestyle with patient, and patients have been more successful in managing their risk factor after completing the program. Lots of patients have reported as well an improvement of their quality of life. And finally, patient can choose from a multitude of programs that we offer, which is geared to meet their own personal needs and goals. So I'm open for question at the moment. I don't know if we have question in the chat. If not, I can also place my information, my email here, if ever you want to send me a question as well. And I would like to introduce our next guest speaker, Joanne McNeil. She's a registered dietitian, and she will be presenting on preparing and optimizing patient prior and post cardiac surgery.
Hello, everyone. Thank you so much for having me today. So what we're going to discuss next is nutrition and ERAS. And the great part about nutrition is that everybody is involved, and it's really a team effort to provide the nutrition to patients pre and post surgery. So for ERAS nutrition, malnutrition is a strong predictor of post-operative outcomes. So when somebody is well nourished prior to surgery, then certainly their post-recovery is much quicker, and they may have decreased infection, better organ function, better blood sugar control, and certainly decreased nausea, and better return to activity. So all these factors have a big impact, especially on nutrition, and nutrition can have a big impact on these factors. So according to the Canadian Malnutrition Task Force, that looked at about 18 hospitals over the past few years, about 45% of patients that are admitted to the hospital are already malnourished. And that number can actually increase pre-surgery as well. So it's can have a big impact on outcomes. So as we know, malnutrition can have a big impact on decreasing healing, increasing infection rate, and also increasing mortality, increasing the cost and the length of stay as well. So on average, what they found is about it can increase the cost of the stay by about $1,200 to $1,500, and it can increase the risk of readmission and also increase the risk of mortality when somebody is malnourished prior to surgery. So there's so many barriers that impact nutrition when a patient is in the hospital. And many times nutrition or the menu or the food in the hospital is the brunt of every joke. But if you see at the bottom, what really only 5% of patients find that the food isn't as to their liking in the hospital. There's so many other barriers, whether it be constipation. So for our patients, we have our patients on a bowel protocol, maybe nausea post-operatively. So we're really making sure that we place patients on a antiemetic or maybe a prokinetic post-surgery. Some patients aren't able to see their food, so making sure that they have their glasses. Some people aren't able to reach their tray, so making sure that their tray is close enough to them, that they're able to open their packages, that they're able to use their utensils positively, and then also any disruptions or maybe tests during mealtime can have a big impact on patients' intake. So because of this, all of us are involved. So the whole team is involved. So whenever you're going to see a patient in their room, we really encourage everybody to ask, can we help you with opening your milk carton? Can we get a pencil for you to help you fill out your menu? So all of us are really involved. So anytime we go in the room, we can help a patient increase their intake, but just by either positioning or helping them with their tray, or maybe helping them with feeding as well. So pre-op, what we do, the patients will meet with their surgeon about 6 weeks preoperatively, and the surgeon will ask questions. Have you been losing weight prior to this visit, or has your appetite been decreased for the past week or so? And if they answer yes to both those questions, then they will automatically refer to the dietitian, to the outpatient dietitian prior to surgery. So the outpatient dietitian will meet with the patient, review higher protein, higher calorie strategies, and help with promoting positive intake or good intake prior to their surgery. And one thing that's recommended as well, and it's been well studied, is to provide 2 nutritional supplements. It doesn't have to be a commercial brand like Ensure or Boost or Premier Protein. It can be a homemade nutritional supplement as well, or shake that they can make, and taking 2 per day prior to surgery can have a large impact on post-recovery. So looking as well at their hemoglobin A1C, and Kim Twyman will be discussing that later. And one aspect as well with ERAS, especially with cardiac surgery that they looked at, we don't usually look at albumin when they're in hospital. It's not a good nutrition indicator, but pre-op, it can be an indicator of malnutrition. So that's one area that we would look at as well. So post-operatively, getting them back to eating as quickly as we can. So within 48 hours after their surgery or post-extubation, making sure that we can offer them some type of nutritional supplement or clear liquids. Some patients even post-op day one are able to have something to eat maybe later in the day. So starting that nutrition early can really have a big impact on their post-recovery as well. Asking them to bring in foods from home, the family can certainly do that. Helping them fill out their menu, all that can have a really good impact on helping them eat better. Post-discharge, for our patients that haven't been eating well in hospital or even pre-op, we recommend continuing with a nutritional supplement for about a month after their surgery or after their discharge. So really what's important is that we've taken this from the University of Waterloo. So has your patient eaten enough today? Please let us know, and that it will make a big difference on their impact on their nutrition. So eating your medicine. Please let us know if you haven't been able to have you missed your tray, and we will make sure to provide a meal or a snack for you for any missed meals or any missed snacks. So post-discharge, certainly if you find that somebody continues to be malnourished post-discharge, there usually is a dietitian affiliated with the hospital where the cardiac rehab is taking place. Or if not, you can contact the Heart Institute at the number here and make a referral to the dietitian, and we'd be happy to see them. Are there any questions? Then if not, I'm going to pass on the presentation to Julie Sawyer. Julie Sawyer is the care facilitator for the Division of Cardiac Prevention and Rehabilitation.
Preparing and optimizing our patients prior and post cardiac surgery. So as you can see here on this slide, number 3 is smoking and alcohol cessation. So smoking cessation is a very important preoperative component, which can promote better outcomes for patients pre and post surgery. And a variety of studies show that long-term quit rates are actually higher in patients who quit in anticipation of the upcoming operation. So the objectives, I'm going to discuss why smoking cessation is so important to the Enhanced Recovery After Surgery guidelines. Then I'll review the role of the Quit Smoking program and how they optimize patients prior to surgery. And lastly, what you can do as healthcare professionals to help patients during admission and discharge. So the ERAS guidelines here clearly state that smoking and hazardous alcohol consumption should be stopped 4 weeks prior to an elective surgery. The recommendation for smoking cessation is very strong for cardiac surgery patients, and there are decades of research and studies done on the long-term effects of smoking. We know that improving patient knowledge of the perioperative risks of smoking and increased physician advice to quit improves smoking abstinence at surgery. The effects of smoking on surgical outcomes. Tobacco use decreases tissue oxygenation, which can lead to an decrease in wound healing and tissue repair, increase the risks of breathing problems, infections, wound-related complications, and blood clots, and also leads to longer hospital stays. So our aim is to have patients become smoke-free as early as possible prior to their surgery. Ideally, the 4 weeks prior, as inflammation caused by tobacco on a cellular level is reversed in about 4 weeks' time. The benefits of quitting are actually immediate, and they can be seen in as little as 8 hours after quitting. Quitting smoking can greatly improve our patients' quality of life. And as you can see on this slide, within 2 weeks to 3 months, the blood flow through the body and airflow through the lungs are actually improved. So it's never too late. I should also mention that while the e-cigarette use and cannabis smoking isn't identified on the ERAS cardiac components, I think it's important to mention that they're not without risk for surgical patients. And while more research is needed, we know that if you are inhaling anything at all, it increases your risk of respiratory complications. So our process has the patients answering in our IVR interactive voice response follow-up call that they have used tobacco in the last 6 months. From there, the RN monitoring these calls will contact the patient and offer a referral to the quit smoking program, or they may have already been enrolled. That RN will then make a referral to the program, and the RN in smoking cessation will call the patient within 24 to 48 hours to schedule their first appointment with them. They aim to follow up these patients about every 2 to 3 weeks on a modified schedule before their surgery takes place. The appointments are offered in person, over Zoom, or by phone. They can prescribe nicotine replacement therapy, Champix, Zyban, and offer individual counseling. Note that they can also send up to 12 weeks of nicotine replacement therapy if the patient does not have coverage. Tobacco use disorder and nicotine addiction is a complicated addiction that affects patients physically, emotionally, and psychologically. It can often be their only coping mechanism for stress, which can make quitting hard prior to a surgery. So it's important to provide patients with the necessary tools to help them reduce and quit smoking prior to their surgery. On admission, the quit smoking team can actually offer and counsel patients and register them for our automated Ottawa Model follow-up program, where patients will continue to be followed by the Ottawa Model follow-up program for an additional 6 months. And they can also send them an additional 6 weeks of nicotine replacement therapy. So as nurses and healthcare professionals, please make sure to make that smoking cessation consult in Epic. Call or page the quit smoking team if you notice your patients having cravings or nicotine withdrawals. So upon discharge, if you know a patient is interested in the quit smoking program, please have them register by calling or emailing on the following link here. And I will leave Emily Serrano's email address up there if you have any questions specific to her. Thank you, and I will pass it over to Kim Twyman, our advanced practice nurse for diabetes.
Thanks, Julie. Good morning, everybody. I always like to talk about the little diabetes program that could and can. The boss is here. We're 10 years this year, our clinic, so it's quite exciting, the growth, and we just keep on growing. So it's very exciting to be able to talk about the program for sure. So as you all know, I'm sure hyperglycemia is forefront in our building and in everybody's world if you're in healthcare for sure. What our job here is to break this awful cycle for sure. There's so many variables that can impact glucose, and we just want to break this cycle so we can get better blood sugar control. So the adverse effects of hyperglycemia are certainly seen in our surgical population. We see increased post-op infections, slower healing, longer stays, and often we can see rejection in our transplant patients. So for those living with diabetes, prehab, while the people are waiting on our surgery wait list, often they become quite deconditioned. They're sitting at home doing nothing. And so the whole idea of prehab is to get them moving again, get them under better control before they come into the hospital. So as everybody's mentioned, we've got this great little video and we've got a follow-up phone call. So when they call back, if they've got questions, anybody who's got an A1C that is greater than 7%, so the ERAS goal is 7%. Anybody with an A1C greater than 7%, if they don't have a diabetes team already in the community, then they're referred to one automatically. If they're above 8%, this is where I come in at this point. I'm consulted and I'll work pretty closely with the people on the phone and with my team members in prehab. They're very helpful in collecting blood glucose levels for me. And we really strive to get them under better control while they're waiting before surgery. And this could mean adding medications and even adding insulin while people are waiting for surgery. So while they're in the hospital, as Joanne mentioned earlier, there are so many variables that aren't in our control, and we can certainly do better at managing glucose. If it hasn't been done, so if the patient comes in as an urgent case, then of course we're going to draw their hemoglobin A1C again. It gives us a baseline so we know where they're at. If possible, we'll continue their usual regime. Unfortunately, some of the diabetes pills can impact renal function and liver function, and sometimes they do need to be held preoperatively, and people would be moved to insulin regime. We really try to avoid using sliding scale. It's a nasty word in the diabetes world. We prefer to use a basal bolus regime with the correction insulin. This way, it really does avoid hypoglycemia. You're not chasing blood sugars the same way. So these are the targets. Oh, yeah, there is a little gremlin here. So I do apologize. One of my lines got messed up. So these are the targets for the non-critically ill while they're here in hospital. We want them to be 5 to 8 before meals. If it gets checked, you know, at different times throughout the day, which sometimes can happen, anything less than 10, we're quite happy with. In the critically ill patients, so this is people in CSICU, 6 to 10. Intraoperatively, there's still some discussion out there about what the targets should be. At this point, ERAS is recognizing 5.5 to 11.1. And what we at Diabetes Canada, the clinical practice guidelines say, once the blood sugar starts to get into that 8 to 10 range, IV insulin should be initiated immediately without any hesitation to avoid getting those blood sugars up into the 11 range. What we find is once the blood sugars are up there, it takes a long time to get them back down. Yes, we have rapid acting insulin and yes, we have IV insulin, but when the blood sugars are high, it's almost like a toxicity in the blood and it takes even more to get it down, along with all those stress hormones, right? Impacting the increased glucose levels. And so the rest of the targets are there for you while they're here in the hospital, and those come from Diabetes Canada. I'm drying up. I'm just going to grab a drink. Sorry about that. So correction insulin alone is not enough, or the old sliding scale, if you will. This is an example of one of them. And I've got some studies coming up, and I just want to sort of demonstrate what happens when we use only correction scale. So in this case, the patient's blood sugar is absolutely perfect, 6, at that 4 range, or sorry, 6.0. And then after they eat, which could be a full fluid diet, right? Full of juice and Jello, and who else knows what might be on that tray, ginger ale in between meals. And it drives the blood sugar up before lunch. Okay, and then it's all the way up to 14. And using this scale, we're going to give them 4 units of insulin, and look how quickly that blood sugar drops back down. These swings are not great, and chasing blood sugars is not helpful at all. Having swings like that, I wish we could put everybody's blood sugar up so you understand how awful it feels. I think working in diabetes for this long, talking to folks about how they feel when their blood sugars are high, when they're not used to it, is really important. And it really does impact how they feel and how they recover. So again, we're not going to do anything at lunchtime, and there we are feeding them some more juice or Jello or whatever's up on the tray. As we know, as Joanne mentioned, the trays aren't always the best, and people are bringing food in from home as well. And there we go, driving that blood sugar up again because no insulin was given with that meal. And what do? We're going to correct it. And because they probably didn't eat very much, maybe at supper, by bedtime, they've crashed on us. Okay, so this just shows how it's not helpful to be chasing blood sugars. Really what we want to do is mimic what a healthy pancreas is supposed to be doing, even in people that are not insulin dependent. So everybody always thinks this should be only for type 1 people, but our people with type 2 diabetes who are under a lot of stress, and post-operatively here at the Heart Institute, it's stressful, right? For sure. And their blood sugars are going up. And so this is the best way. This is the treatment of choice, and this is the recommendation by all the guidelines. So here's an example of using that basal bolus regime. So we've given them 8 units, maybe of Lantus or some long-acting insulin that lasts for 24 hours. And it doesn't necessarily need to be given just in the morning, as long as it's once a day is what's really important to get them started. People often get hung up and think this insulin should only be given at bedtime. But when we transition people from IV insulin to a basal insulin, whatever time that happens, it happens. And so that's when the basal insulin gets initiated. So in this case, the blood sugar is still a bit on the high, or actually still in target at 6. And because we know this person, we're going to give them 6 units of insulin to cover that glucose or that carb tray that's in front of them. And their blood sugar by lunchtime is perfect. Don't have to do any correction. Maybe they overate at this meal. I'm showing what's happening here now. So maybe again, we've got a high glycemic index meal here and the blood sugar has scooted up to 12. So we're going to give them the bolus amount, but a little bit of correction. And then we're not going to drive them quite so low at bedtime. And by morning, that basal insulin will have maintained that blood sugar pretty much overnight. So the sooner we can get the blood sugars down, the better. This is just a study, and it's getting kind of old. I looked at this slide today, 2007. So the rabbit study, the first one was done on all comers in the hospital, and the second one was done just on the surgery population. And you can see that top line really shows the ineffectiveness of sliding scale insulin, and then the bottom line shows how the basal bolus regime works so much better. And this is just a whole lot of studies out there that talk about IV insulin protocols. And these were very instrumental in helping us move forward to transition IV insulin from the CSIU to the wards into a basal bolus regime. And you can see it's very heavily weighted to the infusion side. So it's really important that our folks get good IV insulin post-operatively in the CSICU and in the OR. So post-op, as everybody's been talking about the IVR, and we've also got telehome now calling our surgery patients. This is a really good safety net for our patients that have gone home. The flag diabetes calls ask them if they've stopped their medication. It asks them if they've had any hypoglycemia. Those are just 2 of the examples that are flagged. And if they get flagged, then our diabetes nurse calls them back to determine, hey, why did you stop your insulin? And what happened with the hypoglycemia so we can get that corrected. The telehome monitoring is actually gathering glucose levels. So as soon as we see something that's abnormal, they're reaching out and we're trying to get those blood sugars under control very quickly. There's lots of phone follow-up. People who are newly started on insulin in the hospital are often followed up by myself or my colleague post-operatively just to see how they're doing. Interesting, you know, when I started this job 11 years ago, I always told people once you're on insulin, you're always on insulin. And now we know that that's not the case. There are lots of great medications out there. Even though they may need insulin while they're here in the hospital, quite often, once they get back into their regular routine and they're eating healthy and rehab gets them moving again, often we can stop that insulin. So people are quite motivated. I've got to tell you, this is the most motivated bunch I've ever worked with in my career. And they really do a great job post-operatively. we have a medical directive for managing glucose in the hospital. And automatically, if somebody doesn't have a diabetes team, they get, if they haven't already been referred to a diabetes program, they get one. And if they don't have an endocrinologist, then they're followed up in our diabetes clinic here. It's very intensive management with Dr. Amel Arnaud, our endocrinologist. It's mostly medical management for sure. Not a lot of teaching happens in that clinic. We really rely on our community partners for all of the diabetes education that is done for our patients. When I say an intensive diabetes clinic, it's really hard to get in to see an endocrinologist. You can wait like 6 to 9 months. So the reason why we got this clinic going is Dr. Arnaud and everybody else wanted to get these people seen quicker. So they're often seen within 4 to 6 weeks of discharge, and they're intensively managed every 3 months for the first year. That wouldn't happen in any other diabetes clinic. So we're very fortunate to have this spot to get these people under control. So these are just a summary of my key messages. I think I've hyped on insulin enough. You guys might have that message already. And just being proactive about glycemic management before, during, and even after surgery. And hopefully for the rest of their lives, we can keep it up. And that basal bolus regime is so important. Don't rely on correction scale or sliding scale alone. And the glycemic targets. I think we forget in the hospital sometimes when correction scale is just ordered, it says not to do anything if the blood sugar's 10. And so if you don't do anything, if the blood sugar's 10, the next time it could be 14. And by that time, we're chasing the horse that's already left the barn. So we really need to be proactive about blood sugar control. And this is me. So certainly, you know, post-discharge, my number is on the IVR calls. Telehome follows up with me as well for people who need more intensive management. And if you have any questions, I'd be thrilled to take them. This is a quiet bunch, except I know Mark always has a question for me. Oh, sir. Okay. Oh,
There it is.
Mark, so I was just told we're supposed to do questions at the end.
Okay.
I apologize, but we'll get you at the end for sure.
Okay.
All right, so I'll just echo what Kim just said, that we'll have a group question and answer period at the end for everybody. So hang tight for that. So again, my name's Amy and I'm the advanced practice nurse for cardiac surgery. And what we're going to talk about a little bit today in regards to the ERAS is surgical site infection and optimizing outcomes for patients. So why? So what we know is surgical site infections are now the most common and costly of all hospital-acquired infections. They account for about 20% of all infections in the hospital. They're associated, of course, with increased length of stay and a 2 to 11-fold increase in risk of mortality. And of course, although most patients recover without long-term adverse issues after that, about 77% of mortality in patients with a surgical site infection can be attributed actually to the infection itself. So one of the most, what is a surgical site infection? So one of the most widely used definitions comes from the CDC. So the Center for Disease Control and Prevention. And this definition is used for research. It's in a lot of the guidelines for quality improvement, public reporting, and pay for performance comparisons. So according to this definition, surgical site infections are classified by the depth and tissue spaces involved. So superficial involves only the skin or the sub-Q tissue, and deep involves the fascia or the muscular layers and an organ space. Surgical site infection involves any part of the body open or manipulated during a procedure, excluding the above mentioned layers. So definitely, as you all may know, there are risk factors for surgical site infections, and there's kind of different areas of risk factors. So some, as you may know, are potentially modifiable patient risk factors. So these are kind of the ones that we kind of focus in regards to the ERAS program. So you've heard of these from my colleagues as well, Kim just now, but the glycemic control and the diabetes status, the respiratory status, alcohol and smoking status, pre-op albumin, obesity, and immunosuppression, and pre-op inadequate skin prep, hair removal, antibiotic administration, and duration. The non-modifiable patient risk factors are things that are not modifiable, but we know through research can increase your risk are, of course, people with an increasing in age, recent radiotherapy, if you have a history or a presence of a pre-existing skin or soft tissue infection. So there's also facility risk factors that include, OR room traffic, sterilization of equipment, and intraoperative risk factors. Of course, time on pump, making sure of maintenance of asepsis, and these types of things. So where are we? There's been many different programs at the Heart Institute that work together to help look and increase the quality of patients for our patients, including our overall surgical site infection rate. Just from, comparison from 2020 to 2021, there has been a decrease in surgical site infection rate. There has been a decrease in readmission rate, and as well as length of stay. And again, there's many programs that are attributing to these factors. So one of the things with ERAS is also, of course, the guideline about having a care bundle of evidence-based practices recommended to reduce surgical site infections. So definitely here at the Heart Institute, we do have a surgical care bundle or an SSI prevention care bundle. So this is derived definitely by our quality department, Bonnie Bose and Sam Soublier, and the entire surgical team. So there's many factors that are involved in this care bundle. So I'm just going to talk about some of these things. So just as a quick kind of summary for prevention, there's topical intranasal decolonization that's recommended to help prevent surgical site infection. There's appropriate timing of perioperative prophylactic antibiotics administered fewer than 60 minutes before there's actually cut down to the skin. Depilation protocol, so that means like our clipping prep and pre-op skin, the chlorhexidine wash before surgery, and dressing protocol or policy and procedure, and daily incision washing with chlorhexidine, potentially beneficial as well. So implementation of practice. So here at the Heart Institute for our patients, as part of the guidelines and that surgical site bundle, we know that Bactroban evidence supports this topical intranasal therapy to eradicate the possibility of a staph colonization. So from 18 to 30% of all patients undergoing surgery, they can be carriers of this staph and not even know. And so patients who are carriers of the Staph aureus, they're 3 times more risk to have a Staph aureus surgical site infection and bacteremia. And it's recommended the topical therapy be applied to help prevent this. So the way it works here, it's a nasal ointment. The patients apply it to both of their nares twice a day for 5 days preoperatively at least. And it's initiated on the day of acceptance for surgery. And it should be done within 60 days of their surgery date. So pre-op shower or bath. So all of our patients before surgery do have this pre-op wash. And we know that it's possible that this can decrease skin surface pathogen concentrations. So I see one of our educators in the audience here for the OR, Anna Lee. So she'll talk about this as well and educate all of our staff as well as the other educators, the importance of pre-op clipping. So not shaving, but making sure our patients have proper clipping. And we know that it's actually best closest to the time of the OR. so not in the OR. We know that shaving, we really echo to our patients, it's important not to shave preoperatively. We know that that can increase infection risk. So clip only. And we always try to make sure patients know not to, try to prep and do things on their own and try to pre-shave before surgery, and let them know that we'll clip and we'll do that for them. So another big thing that we know regarding lines and drains, catheters, there's many guidelines about this that, try to making sure that these are removed when they can be. So assessing removal daily with with the team. So this can decrease surgical site infection and increase better outcomes for our patients. Our educators here at the Heart Institute have developed a policy and procedure for sterile dressing removal, and it's within the 48 hours, including policies for incision care. So that's developed here and already has been going for quite a while. And then, of course, the next thing I'm going to talk about is actually about pain. So recommended guidelines for pain in regards to ERAS. So after surgery, of course, one of the big things for anyone going for heart surgery, it's important to know that you are going to have pain. So we try to make sure that we educate our patients to understand that, but to understand that we're here to help make sure that they're comfortable and for them to communicate that with us. And we know that this can actually help better out their outcomes after surgery. So there are actually class 1 level B guidelines in regards to pain control after heart surgery. And there's sufficient evidence to recommend the use of Tylenol or acetaminophen, tramadol, and the gabapentin for multimodal opioid sparing pain management. So it's essential for post-op recovery. So clinicians must assess procedure and patient-specific factors to individualize multimodal pain management. Education is key, like I just talked about, encouraging the patient to become an active participant in their own care. Definitely here at the Heart Institute, the staff are always asking the patients, every hour, how are you feeling? What's your level of pain? But it's important, of course, I know we have a lot of people on the line today within the region who might see our patients later on post-operatively when they're starting to recover, to make sure that we also echo that message to patients, making sure, if they're having, 2 or 3 out of 10 pain, to make sure they're taking their Tylenol or acetaminophen around the clock as directed by their prescription or on the bottle, to make sure that they're comfortable. They can go for their walks. They can sit up and have their lunch comfortably. All of these things that we know are very important to help these patients get better after surgery and get stronger. So this is just another part of the bundle, and you guys have already heard about this, but the importance of smoking cessation before surgery. And just to echo Emily and Julie's message, the importance of, trying to really message to patients if they can kind of focus not necessarily on stopping smoking or quitting smoking, but if they can kind of think about stopping smoking even just 4 weeks before surgery and after surgery, it could significantly improve their outcomes. And I know Emily and the smoking cessation team have really been echoing that and have had really great success with that messaging for these patients. It can be quite helpful. We know, of course, that this can improve our patients' outcomes and decrease, ventilation times, length of stay, and wound complications. And again, to echo again in the surgical site bundle, the importance of glycemic control. Kim just explained that very well in depth. So very, very key factor. To echo Joanne, that food is medicine, the importance of protein before and after surgery. It's essential. A lot of our patients, they're not that hungry after surgery. They might have some extra gas, they might have some constipation, they just had big surgery. But we talk about the importance of making sure that they are eating, even if they're not that hungry, 5 to 6 small meals throughout the day instead of 3, making sure that protein is really important for them. This is not in the ERAS guidelines, but bras. So bras and surgery. So one of the things that is in some of the research for people after having surgery, that if you have a C cup or higher breast size, that wearing a bra after surgery most of the day, most of the night, can actually possibly decrease the amount of pain you experience if you have sternotomy, because it can decrease the pull on the incision, you can imagine, even when you're lying down. And it also can possibly decrease your risk for a surgical site infection, because it can decrease a superficial dehiscence. So that's really important that we do message to our patients. But again, that's not in the ERAS guidelines, but we do echo this to our patients, that it's very important. So another thing that's in the that is in the ERAS guidelines is patient and key learner engagement tools. So one of the big things is we always really echo that it's important that our patients listen to the information that we're giving to them about their health, but the huge importance of having their caregiver or whoever's going to be with them after their heart surgery listen to the information as well, because we know that this can actually decrease the readmission for a patient, and it actually can make them do better. So it's a really big part is that we have patient and key learner or caregiver involved in all of the step of the way. We have tons of patient resources. PS, we'd be happy to share any of these if you guys ever want to reach out. They're available on our website as well. We used to have a discharge class. It used to be in person on the units for patients and their caregivers to come to. And then of course, COVID happened. So that actually helped us develop a really great new resource that's available virtually. So it's a live virtual class. It's every Monday, Wednesday, Friday. So we have our patients jump on as well as their caregiver. We also put this information on the patient's after visit summary. So the information to link onto the class after they've been discharged home, so they can sign on when they're at home on their own comfy couch having a cup of tea or something, where it's a little bit of a better environment for maybe keeping that information and actually being able to listen to it. And of course, we make sure that we echo that the caregiver should be attending that too. Very important. We've actually had some healthcare team from around the Lynn as well jump on. So if anybody on the line anyone ever wanted to, just jump on just to hear what we do, educate to our patients and to their caregivers, you guys can always jump on. It's available on our website under the calendar. So again, I know we have some people on the line today who might have our patients within the region, within their rehab programs. So if you have a Heart Institute patient and, they're post-op and they're doing their rehab with you guys, really, if you have any questions, if you have any issues, anything like that, you can always contact us. My information's right there, my email, and you can always get a hold of me at that phone number as well. Monday to Friday during business hours. And that's it. So I just want to say thank you guys so much. And just in conclusion, that we know that ERAS protocols decrease unnecessary variations. They improve quality, safety, and value for our patients. The multidisciplinary approach is imperative, getting everybody on board and working together. And yeah, I'd like to invite the other presenters up here, Julie and Tammy, and we'll just open it up to see if there's any questions for the team. Thank you, everyone.
Thank you so much, ERAS team. There's a few questions already in the chat for you guys. One is from Saba. This question is asking about if there's anything that would make patients ineligible for the cardiac rehab program post-op.
I will take that question gladly. So basically, we do have patients have eligible and ineligible criteria, and we screen for those when patients are discharged from the hospital, and we can make automatic referrals. That's part of my role to identify those who are eligible or ineligible. But the main thing would be if a patient had a cognitive issue that would impair them from being able to retain or learn and participate in education, or if they were palliative, end of life. Sometimes we don't get them involved, but we do still supply education to those patients if they require. And if they are transferred to another facility for further care, we can also have them re-referred back to us and see if they're eligible after they've finished their treatment. So the long and short is we are inclusive to everyone, but there's very small population that aren't included in our program. Thank you.
Thanks so much. There was also another question from Kristen about the OMCS program. Now I'll just also mention that we have a session later this afternoon that's dedicated to smoking cessation. But Kristen's question is asking about what NRT products are available for clients. Is it only the patches, or are there lozenges, inhalers, gum, and spray as well? And are there any compassionate programs for clients waiting to use like Champix or Zyban with no drug coverage or are low income? Thanks so much.
Yes, so Emily did advise me that I may be asked this question. And like I did mention in her presentation, patients are offered up to 12 weeks of nicotine replacement therapy, which would include patches, lozenges, or inhalers. And then they are followed by the Ottawa model as well. And they're also offered an additional 6 weeks of nicotine replacement therapy if they do have financial burden. So they really do try and work with the patients to offer them as much as they can. And it includes Champix and Zyban as well. Hope that answers your question.
Thank you. There is a question for Kim from Neil. Is there any coordination or communication with food services in-house to provide patients with glycemia issues with a specific diet that can curb spikes after mealtime while they're pre-op or post-op?
Yeah, it's a very good question. So of course we have a diabetes diet tray. Joanne can help me with this one too. But unfortunately, you know, we're feeding the masses, right? So it is challenging to avoid high glycemic foods, particularly with a full fluid diet. And full fluid diet isn't so bad. We need to get the carbs for sure. But you're right, there is a huge spike with high glycemic foods, and really we just have to address it ahead of time and to avoid that spike, because people have to start drinking, right? Certainly Boost and some of those other proteins help slow that glycemic index down. So if somebody can tolerate that before they actually start eating, that will slow down the peak of that rise after eating. Joanne, did you want to add anything?
Yes, absolutely. So for our diabetic patients, what we would do, they would be receiving the Boost Diabetic. So it only has 17 grams of carbohydrate per supplement, and so it's a lower glycemic index. And certainly they do receive clear liquids, but most patients on the first day would only probably be taking per meal about 45 grams of carbohydrate per meal, including the juice or including some type of their soup or the Boost Diabetic. So it's not an excessive amount of carbohydrate. They do have a higher glycemic index, but we're not exceeding 45 to 60 grams of carbohydrate per tray for those patients.
Thanks so much, Joanne. We have a few more questions. I'll just go through one from about sternal wounds. So maybe I'll refer this to Amy. There's a question here about protecting the sternal wound from telemetry wires if still needed once a wound is open to air.
Yes, that's actually a really great question. So at the moment, we actually, again, I kind of talked about it before, but we try to remove lines, tubes, and it's not part of ERAS guidelines necessarily, but we also try to remove telemetry as soon as possible. So if the patient's doing well and there's no arrhythmia or anything like that, we would actually remove their telemetry after before the dressing actually was removed from the OR time. And then in regards to patients on the unit with telemetry, there are, we did do kind of a little pilot where we were having the surgical incision covered while the patient is on telemetry, and making sure there's actually a protocol as well to make sure that the telemetry and the stickers are actually assessed daily and cleansed daily as well.
Thanks, Amy. And one more question, maybe for the whole group. There's one from Ray. His question is, are these discussed pre-op involvements used not only to optimize for surgery and post-op outcomes, but also potentially dictate appropriateness for surgery? And do you have any examples? Does it make a patient a better fit, if you will, for surgery?
Yeah, so if I kind of understand the question a little bit, definitely it's actually it optimizes patients. So there's actually been patients, I know Kim would probably speak to this, where the surgeon is like, you know what, their heart-wise, the patient is stable, and we're going to hold off on doing their heart surgery until Kim is helping the patient optimize their glucose before they actually go for their surgery. There's also been many other things. Maybe it's social aspects. Julie probably comes across these things all the time. And then on the vice versa, it's actually been shown because we also screen patients within the prehab program for symptoms while they're waiting at home. Julie's going to talk about that actually way more in depth shortly, but screen for symptoms. So it's actually done the vice versa, where we've actually had patients been bumped up for surgery dates because they didn't even realize that they were having increasing symptoms, but they've spoke with the nurse and they've screened that out. So that's on the vice versa as well. And then there's also been situations where, again, I don't want to speak for Julie, but she's going to talk about this more in depth soon, where these patients will actually maybe be seen in person and assessed in person, and it might have the patient have to have a little bit more multidisciplinary team approach to assess what would be the best for the patients within their goals of care, if they need to see their surgeon again to reassess, etc.
And from a physiotherapy perspective, we hear a lot that patients who are elective and they view the series on YouTube about prehab, they know exactly how to transfer and they have practice at home, and the physiotherapist can vouch for that after surgery, they're able to move a whole lot better as well. And it's a quicker recovery, and often they go home sooner.
Thank you so much, ERAS team and presenters, and thank you everyone for your questions. I'm sorry we don't have time for all of them.
Sandra, sorry, Sandra, but just that Mark has a question, and I don't want to, I want to give him the air for that because we turned him away in the middle before. So ask your question, Mark.
Okay, just, I don't know if everybody can hear me. Yes? Okay, little case presentation very quickly, and a testimonial to the diabetes team. Gentleman was admitted to Montfort with ACS in mid-March, was transferred here for invasive angiography, found to have triple vessel disease, and coincidentally identified as having an A1C of 9.2%. Underwent CABG, and I spoke to him this morning, repeat blood work. He is now at an A1C of 7% and has a follow-up with Dr. Arnaud on Monday. So hats off to the diabetes team.
Thank you so much, Mark. Great story. Okay. On to, on a similar vein here, so a little bit more about the prehabilitation program and optimizing your patient for cardiac surgery with Julie Sawyer. So I'll read a little bit about Julie here. So Julie has been a nurse at the Heart Institute for 14 years. She has extensive experience in caring for cardiac surgery and cardiology patients, which includes experience with our transplant and LVAD population. Julie has now transitioned to the care facilitator role in cardiac rehab, where she has developed and participated in many quality initiatives, professional presentations, and Heart Institute committees. She has been involved with streamlining processes and program changes, which have led to the increase in patient enrollment in cardiac rehab. Wow. She is also passionate about optimizing patients before their surgery with the prehab program by being able to provide education and reassurance based on her previous clinical experience. So I'll turn it over to Julie.
Thank you, Bonnie, for that lovely introduction. So I am here to talk to you all about how we are optimizing our patients prior to cardiac surgery by using innovative technology. So how can we optimize our patients while they're waiting at home? Well, we have this unique opportunity to use while they're waiting for their surgery in this prehab period as a time to educate and prepare elective surgery patients for their surgery and to address any patient or family anxieties related to the surgery. Before the pandemic, we used to have a group of patients come on site to have prehabilitation course. And a lot of times the patients found it time consuming and they didn't want to pay for parking. So COVID kind of helped us out, and we were able to develop our program to be in line with the ERAS guidelines. By having our patients screened in the prehab program, our objectives were to screen all the preoperative elective patients using the ERAS guidelines to identify those who were at risk or requiring optimization. So our outcomes were to improve patient post-op infection rates, improve glycemic management and understanding, decrease their post-op length of stay, improve the patient mobility preoperatively, increase their satisfaction, increase smoking cessation, improve their nutritional status, optimize their after-discharge care, decrease the patient and key learner anxiety for the upcoming surgery, and of course, increase their enrollment into cardiac rehab. So our institution implemented the prehab program using the interactive voice response automated call technology. This is a series of questions that were developed with the multidisciplinary team based on the best practice guidelines from ERAS, where we will screen patients for malnutrition, their diabetes control, whether they have a discharge plan in place, any mobility concerns they have. We also ask if they've had dental work done if they're a valve patient, and we ask them about their smoking cessation and screen for any anxiety or depression. We also perform a symptom assessment question and provide interventions if needed. We collected a SF-12 quality of life assessment at baseline to be compared post-operatively. And we also confirm whether or not they have watched the educational video. So this educational video series was developed by the multidisciplinary team as a patient education video set up sort of like a Netflix series. So it has 5 parts that the patient can then refer back to at any point and review with any of their family members or caregivers. This link is actually sent to the patients with their acceptance letter for surgery by the surgical triage office, and they're asked to view it as soon as possible. We also offer a once a week while you're waiting for cardiac surgery Q&A for patients to come with their caregivers, where we have a registered dietitian, we have the advanced practice nurse, Amy Charlebois, and a physiotherapist, where patients can ask their questions or make concerns, and they can be provided answers in French or English. So the prehab program process begins with the identification of the elective surgery candidate. The referral is made for cardiac surgery, and the patient is sent a letter from the surgical triage office with the link to the education video. The patient is seen in clinic by the surgeon, and the patient then agrees to have cardiac surgery, and a surgery case request gets generated. The patients who have that completed case request are then added into our IVR follow-up system. A call or email or SMS will go out to the patient the following day. This is the questionnaire that's provided to the patient with all the screening questions that were developed by the multidisciplinary team, and it then identifies those patients who are at risk by having a flagged response in our system. The RN monitoring that system will then provide a call back to that patient based on those flagged responses. And then the nurse will make the appropriate consults in Epic to the appropriate healthcare providers. So just to give you a quick snapshot, from February 1st to June 1st, from 2021 to 2022, we have actually had 833 patients screened by this system. And given that it was COVID times, there was a potential that we could have had even more patients involved. So as a program snapshot, these numbers here are reflective of the amount of flagged responses the RN monitoring our system would observe, and then during the follow-up call address and make the appropriate consults. So for example, if a patient had indicated in the follow-up call that they have an abnormal glucose level, the nurse would call back and be able to identify quickly in Epic, let's say if their A1C was above 8%, we would then know to automatically have Kim, our diabetes APN, involved in that patient's care. And this isn't sponsored in any way, but I also had the opportunity to have Freestyle Libre sensors available for me to attach to patients who had A1Cs above 8%. And I was able to actually enroll them into the LibreView website where Kim could then monitor their glucose and provide intervention for them and medication adjustments the 4 weeks leading up to their surgery or even before that. So it was actually really fun to be a part of. And provide education to those patients who may need actual glucose monitoring education. And for instance, in the past 6 months, we've actually been able to capture pre-diabetic patients and those with poorly managed diabetes. We've actually made 105 community diabetes education referrals. So having those patients receive the education before they even come for surgery is going to greatly impact their outcomes. We are also able to identify patients who have flagged that they've used tobacco in the last 6 months and make the appropriate referral to the Quit Smoking program, where they can then receive the NRT therapy if needed. And we also identify any malnutrition or weight loss, make the appropriate referral to the registered dietitian. And we also at this time are able to identify any financial concerns and help patients with setting up their convalescent care so they don't have to worry about it before coming in for their surgery. It's already set up for them. And like Tammy had mentioned, we also can make consults to physiotherapy. And for those patients we identified during the call who may need to actually come on site for physiotherapy assessment, we can work with them and set up and arrange an appointment with the physiotherapist to have the patient come in, learn the techniques that they need to be able to transfer in and out of bed safely while keeping in mind their sternal precautions that are coming. So our cardiac surgery program IVR system is allowing us to do extensive screening to identify higher risk and marginalized populations. We're able to screen for any language barriers, any significant mobility issues, and those requiring the extensive glucometer teaching and diabetes education. It also has increased our ability to communicate and set up appointments within our multidisciplinary team by having the surgeons identify these patients early on and get our prehab team involved early. And it has increased our communication even between our pre-admission unit, where we can then set up appointments that we know the patient will be coming in for and be able to make the appropriate referrals and have patients seen all at once instead of multiple different appointments. And during our program is actually going to be soon implementing a 2-week follow-up call for screening for any symptom changes and being able to advise patients when they should seek medical attention, dial 911, or let their surgeon's office know that they've had an increase in symptoms. Because during that call, we're able to communicate with the team if the patient actually needs to come in for surgery sooner. And we have ongoing quality improvement projects to identify program improvements and patient satisfaction. When the patients are also given the surgical triage package, there's also a handout on nutrition and the importance, which Joanne had highlighted. So during our call, we encourage patients to start doing that Take a Boost twice a day in the 4 weeks leading up to your surgery to really help make them understand that that's going to help them heal better and give them more energy going into their surgery. And we also developed the live Q&A session where we can have patients come and ask questions or concerns. So in conclusion, I can tell you that the automated call system has assisted the prehabilitation stage for patients based on the ERAS guidelines and having patients optimize prior to their surgery day. And we actually have preliminary outcome data that has demonstrated significant decreases in institutional readmission rates and surgical site infections by almost 50%. The length of stay has also decreased by 1.24 days for our patients. And feedback surveys have also demonstrated high levels of patient satisfaction. Thank you very much. Am I allowed to take questions now?
You sure are, Julie. We do have a question from C. Middleton. She asked, why are patients with BMI above 30 not flagged?
A BMI above 30 not flagged? Is that the question? Yes.
Correct.
Here at the Heart Institute, we're actually trying to get away from focusing on BMI. And actually, we're going to have a presentation, I believe, after mine about our obesity guidelines. And that's why we actually screen for any malnutrition or weight loss or decrease in appetite. But I will tell you, I've had patients during their call say, well, you know, I just need to lose weight. I just need to lose weight. But when people are in that mentality, we actually don't want them to try and do an aggressive losing weight program prior to their surgery because it's proven that that can actually be detrimental to them in their healing process. So that's why we do these screening questionnaires. And if ever I've identified somebody during that call that may need further education, I refer them to the registered dietitian for further counseling. I hope that answered your question.
Thanks, Julie. And then one more online from Joanna. Do we need to reconsult patients once they're accepted for surgery? For inpatients, as we usually refer them to ambulatory cardiac rehab. So this is actually coming from the general campus cardiology.
So once a patient has had their surgery here, we've actually implemented a new process where the patients who are here within Ottawa region will have their after visit summary printed out for them with their cardiac rehab appointment already on it. So you would not have to reconsult, but we in the automated referral process in cardiac rehab, we will screen patients after they've had surgery and make sure that they do have a referral in place and make sure they are eligible. So I believe, no, you would not have to reconsult. We try and do that for you.
Thank you so much, Julie. I will hand it over to Bonnie to see if there's any questions in person.
Thank you.
Thanks, Julie. Any in-person questions? No? Okay, great. Wonderful. Thank you so much. Let's take this off here. Alrighty, so our next presenter is Cassidy Van Stiphout. She'll be presenting virtually and on the topic of integrating the new Canadian clinical guidelines for the management of obesity into clinical care. So giving you a little background on Cassidy, she has a Bachelor of Science. She's a 2020 graduate from Queen's University. Currently, she is studying at the University of Guelph as a Master of Science for 2021 candidate in biomedical sciences. Complementary to her studies, Cassidy also participates in 2 research projects at the Heart Institute. Her involvement in atrial fibrillation related research, a condition associated with obesity as an underlying risk factor, has led to a publication in the Canadian Journal of Cardiology. Additionally, Cassidy continues to participate in integrating the new Canadian clinical practice guidelines for obesity in adults into clinical practice within the Heart Institute. So I'll turn it over to you, Cassidy.
Sorry, everyone. We'll just get started in just a second here. We're going to just prepare for Cassidy's presentation.
Sandra, maybe just while they're getting Cassidy set up, should we open it up to see if there's any other questions while we're waiting?
Yeah, that's a great idea, Amy. Thank you so much for that. And while you're on stage, there is some questions about sternal infections, so you're probably the best person to answer those. One of them is from Steph.
Yep.
And her question is, if cardiac rehab is delayed due to a sternal infection, what is time frame of returning, assuming VAC dressing is contraindicated?
Yeah, so VAC dressing isn't always contraindicated to the rehab process. So we have had patients who are healing and have a VAC and they start their cardiac rehab program. So it's actually not a contraindication for that, if that answers that question.
That's great. Thank you very much. There was also another question. This one is more related to actually from Julie's presentation, but there were a few comments about our pre-op program. And one of the question was also, can you see this program being replicated at other sites? Yeah.
Yep, I'll let Julie answer that, but
So generally, any patient that gets referred to us for cardiac surgery, we will reach out to, do the screening questionnaire, or they will receive the screening questions, and then we will make the appropriate referrals to our healthcare providers within our institution. But I mean, we, when we have people from out of town, we try and get them seen by whoever we can here. But I think it is coming that we will be referring out to other communities to get their involvement in their patients that are in with their own region, for sure.
Yeah, and just to echo Julie, so for other centers that are thinking of developing a prehab program, of course, just Bonnie Bose had kind of presented our hub and spoke model. Absolutely, we'd be happy to help anybody if they were thinking about at another center to develop a prehab program that may not have all of those pieces set up yet. We're happy to help in any way. So you can just reach out to our team. Sandra Wong can give you the information at any time. And we've already been in touch with some other centers across Canada about our prehab program and just how to develop it and how we started it and how it came about and resources and such that you might need. Other centers have also, the big reminder is like same thing as ERAS and all of that. You don't necessarily have to do it all at once. You can do it one step at a time. And there's a lot of things that a lot of centers are already doing, but it's just kind of smoothing out that process. So I think we've got Cassidy all ready to rock. So I'm going to step off. Thank you guys.
Thank you.
Hello, everyone. Sorry for the delay. I'm glad that we could figure out all the technical difficulties. Can everyone hear me okay? Yeah, okay, perfect. So I figure we might as well just jump right into it. So good morning, everyone. Today I will be sharing our quality project that is investigating the attitudes and beliefs of healthcare providers regarding the treatment of patients with obesity. So these results will be from a pan-institution survey. So during our time together, I will be introducing our quality project, our survey results, and I will finish by sharing how these results are actually being used to guide efforts to improve the Institute's care for patients with obesity. So in introducing our quality project, it's important for me to share our overall objective, which is to integrate the Canadian guidelines for obesity in adults into the Heart Institute's clinical practices. So in order to do this, we first established a multidisciplinary working group, and this working group conducted an extensive literature review to examine biased perspectives and stigmas associated with weight in our environment. So during this review, we hoped to find an established survey to utilize as our baseline survey. So among this investigation, our attention was drawn towards a 2018 study by Bouchard de Latar and colleagues. And this survey was based on literature, exploratory interviews, and an expert committee review. And it was also pre-tested with 15 physicians and nurses. The study's target population had also made it very appealing. So similar characteristics in relation to our own objectives were considered. So for example, those eligible to participate had to be a healthcare professional at a university hospital. They had to disclose their sex, years of employment at the hospital, and age. And they were required to share professional qualifications, specifically education and training related to obesity. So all in all, we felt that this survey would be an excellent tool to utilize for our baseline. And we then went on to share this survey with all Heart Institute staff. So collectively, we had a total of 255 respondents. If we just take a quick look at the demographics of those respondents, the majority of the participants were female and nurses, and the age of participants seemed to vary between 31 and 60 years of age. Additionally, the majority of respondents stated that they had been working at the Heart Institute for over 10 years, and most participants did not receive any obesity-related training since they graduated. Of the few that had, the training was neither extensive and/or did not solely focus on the topic of obesity. So if we look at the respondents' knowledge associated with obesity, participants were asked whether obesity leads to serious medical complications. So over 70% answered strongly agree, with about 20% answering agree. So here we questioned why some were hesitant to say strongly agree. Could this be due to a lack of knowledge in obesity being a common risk factor for other conditions, or maybe obesity as a chronic disease? So these were just some questions that we considered. So next, participants were asked regarding the causes of obesity, what is the importance of the following factors? So here is a list including both genetic and environmental factors, with the commonality of most participants answering very important to most factors. However, one factor that I would like to comment on a little bit further is lack of willpower, where answers varied between low to very important. So we wondered if this was due to people feeling morally obligated to say low importance or say unsure, so choosing moderately important. We had also considered that there may be variability in how one defines lack of willpower. So next, participants were asked about their general beliefs regarding obese patients. And first they were asked, in your opinion, people with obesity are in general lazy or awkward. So respondents answered very similarly to these two questions, and around 40% answered with disagree. However, I do want to note that between 25 to 30% of these respondents answered neither agree nor disagree, and we wondered why many chose to not take any sort of stance on these questions. Were they unsure? Did they just not want to put any thought into it? Or did the question make them feel uncomfortable? So again, these were some questions that we had and some that I would like you to keep in mind as we continue to work through the rest of the results. So respondents were then asked if they felt people with obesity are in general neglected. So around 40% stated that they agreed, but again, we had about 30% of respondents answering neither agree nor disagree. So questions then shifted a little bit to target the beliefs of staff while working with obese patients. And participants were asked whether they liked working with patients with obesity. And again, the majority of respondents answered this neither agree nor disagree option. With such a large number of respondents choosing this option, we wondered if there was another factor other than respondents maybe feeling uncomfortable or unsure. And we wondered in this case if the way the question was interpreted played a role. So did individuals think of this maybe as a comparison in the way that they like working with obese patients over non-obese patients or vice versa? So moving on from that question, patients were then asked if they feel uncomfortable when examining or taking care of patients with obesity. And the majority of respondents chose disagree or strongly disagree. And then further, they were then asked in a working setting, would they prefer that their patients would not be obese? So here respondents had a mix of opinions. And considering that patients say that they feel comfortable caring for patients with obesity, it made us question what other factors could maybe play a role. Is it the lack of appropriate educational resources or the lack of proper equipment that aids in accommodating patients with obesity? So again, these were just some questions that we considered. So next, the questions were aimed towards the beliefs of staff regarding appropriate places and times to discuss weight with patients. So participants were asked whether they believe the time of hospitalization is ideal to discuss with patients his or her weight problem. And the majority agreed or strongly agreed, which showed us that we need to make sure that staff have the tools available to initiate some of these conversations related to weight management. The following question was whether respondents feel afraid to make their patients feel guilty if they discuss his or her obesity. And here we received a similar response to the last question. However, more people in this case chose that neither agree nor disagree option. And in this instance, we questioned whether providing more resources to familiarize staff with discussions around obesity would in fact be useful. So next, the survey included questions that were directed towards current practices in caring for patients with obesity. And here, 90% of staff said that they did not or did not know of any documentation, like flyers, that are at their disposal. And even further, most did not or did not know of any specific intervention tools such as food diaries or decision balances that they could use. So upon reflection, it is plausible that participants just don't have the resources in their department, but it also is plausible that they just do not have the educational background to carry out some of these intervention efforts. So it shows us that more education in relation to obesity management could be useful. So participants were then asked whether treating patients with obesity requires specific training, and the majority of participants agreed or strongly agreed. So our main takeaway from this question was the overwhelming need for additional training, but even more important, it is really important for us to consider what training staff would actually find to be useful. So respondents were then asked if they felt trained enough to intervene with patients with obesity, and most answered disagree or strongly disagree, which again shows us that more training and education is needed. And finally, the last section of the survey asked participants about their attitudes towards plausible intervention efforts that they could see to be useful to improve obese patient care. So evidently, about 80 to 90% of respondents thought that both educational material and training on obesity would be useful or very useful. And similarly, respondents said that protocols to deal with patients with obesity, as well as a list of professionals for referrals, would also be useful. So that kind of brings us to the tail end of our survey. And now I want to share some factors that we considered and some common themes that we found among the results. So for one, it is important to note that our sample size had a lack of physician participants, and our data is more heavily geared towards the knowledge, attitudes, and beliefs of nurses. However, that should not discount the facts that we did have some physician respondents, and these results can still aid in driving intervention efforts for physician staff. The second theme is in relation to knowledge. So it's evident that respondents do understand that multiple factors can lead to obesity. However, it seems that staff were unsure or maybe unclear about how obesity is consequently an underlying cause for some other conditions. And then the third is that respondents expressed a clear desire for additional resources in education, and this desire accompanied by respondents also choosing that neither agree or disagree option for questions related to their beliefs associated with working with patients with obesity, showed that training could be helpful to make participants and staff feel a little bit more comfortable while caring for patients with obesity. So now that we've kind of gone through all of the results for the baseline survey, we are now using those findings to drive intervention efforts. So currently we have several intervention efforts underway. So in relation to education and training, we have begun introducing the topic of obesity guidelines and opportunities to further staff education at events like Grand Rounds or education days like today. And our committee is also developing an education strategy and training programs for healthcare providers based on the outcomes from this survey and input from our partners at Obesity Canada. And then in relation to resources, we have developed a working group to introduce bariatric equipment and proper use of the equipment into the Heart Institute. And we are also restructuring strategies for obesity management. So all staff have the opportunity to watch a dietitian series of videos that will challenge staff to rethink weight. And the aim is to restructure the discussion so that we shift the focus from solely talking about a patient's BMI and instead encouraging patients to reach their best weight. So together, the improvement in resource accessibility and restructuring obesity management dialogue has driven our committee to develop a small pilot study. And this includes a 5-step integration plan, the 5 A's, and that's to ask, assess, advise, agree, and assist. And this is for all healthcare providers to use in practice while caring for patients with obesity. So again, that brings us to the end of my talk. And just before we jump into questions, I do want to just finish by saying thank you for everyone to listening to my talk today. And I would also like to thank my working group for all your hard work on this project. And finally, a special thank you to Bonnie Quinlan, who brought me onto this project and gave me the opportunity to present our work with you today. So again, thank you very much. And if you have any questions, I'm here to answer them.
Great presentation, Cassidy. There is a question from Carolyn. The question is for the survey, obese patients require much more assistance for mobilization and care. So workload is a large factor that we have trouble with, especially over COVID times. Just wondering if you have any comments about that. I believe this is specific to patients.
Yes, so that is definitely something that we reflected on and are considering. So as I mentioned right at the end of our presentation there, we are putting in multiple intervention efforts to improve the care for patients. One of those being a working group to bring in more equipment so it's easier to better accompany the care of patients with obesity. And whether that be equipment or make sure that the patient rooms are a little bit more accessible. So that is definitely one thing that we're considering and hoping to improve moving forward.
Thanks, Cassidy.
My pleasure.
Any questions from the audience here? Okay. All right. Well, thank you very much, Cassidy. That was an incredible presentation. I would also like to just announce a break now, and we're going to have 15 minutes. So maybe if we could have everybody back here by 5 to 11, just so you have your full 15 minutes just to get a coffee and take a biological break. Okay, so thanks very much, everybody. We'll see you soon.
Hi, everyone. We'll get started again. Our next session is about surgical program updates, and it's my pleasure again to introduce to you Amy Charlebois and Tammy Lafreniere. As mentioned earlier, Amy Charlebois is our advanced practice nurse for cardiac surgery, where she participates in patient education, care, and research. Amy has a Bachelor of Science in Nursing from the University of Ottawa in 2007 and earned her Master's of Nursing Science as well as graduate certificate in nursing specializing in clinical education in 2015 from Charles Sturt University in Australia. Amy has a passion for education, which she uses to deliver the best possible care for Heart Institute's cardiac patient population. As well as an advanced practice nurse in cardiac surgery, Amy provides clinical expertise in the field of education and cardiovascular nursing. We also have Tammy Lafreniere. Tammy earned her degree in physiotherapy from the University of Ottawa in 2006. Tammy has diverse clinical experience from private practice to hospital acute care, including intensive care units. Tammy currently works as senior physiotherapist at the Heart Institute, providing clinical and education support for our inpatient and outpatient physiotherapy patients. She's also a member of the heart transplant team here at the Heart Institute, putting forward the physiotherapy perspective to the interdisciplinary committee. And for the last decade, she's also demonstrated her commitment to the physiotherapy profession by assuming the role of clinical supervisor for several students, as well as practice. Sorry, my apologies. Just also to mention, for the last decade, she's demonstrated her commitment to the physiotherapy profession by assuming the role of clinical supervisor for several students, a practice supervisor for residents, and examiner for the Canadian Alliance of Physiotherapy Regulators. Welcome, Amy and Tammy, again.
Thanks so much, Sandra. I also just wanted to, sorry, my mask just got wrapped up in my earring there. I just wanted to take the time just to also introduce Ruth Colton. She's our virtual monitoring coordinator, one of our registered nurses here at the Heart Institute. So she's going to be doing a little talk as well regarding our telemonitoring program. And also, again, we're going to hear from Dr. Mark Ruel, the Chief of Cardiac Surgery. So yeah, just what we're talking about today, just some cardiac surgery program updates, some things that are new, just so everyone around the region is just aware of what's upcoming and what we're doing here at the Heart Institute. So we're going to hear from Tammy shortly. She's going to talk to you guys about our updated sternotomy precautions versus our previous standardized care. It's an update for that. And then also we're going to hear about our virtual post-op journey. So our surgical IVR, which is our interactive voice recording system, and surgical telemonitoring program. So I'd like to start off with a message from Chief of Cardiac Surgery, Dr. Mark Ruel. So thank you so much, Dr. Ruel, for that message. And with that, I would like to introduce Tammy Lafreniere to talk about updated sternotomy precautions.
Thank you for allowing me to present the updates about sternotomy to this great Regional Education Day event. So my name is Tammy, and I'm the senior physiotherapist at the Heart Institute and working for the Division of Prevention and Rehabilitation. So this initiative from cardiac and thoracic surgery team is of course in collaboration with the physiotherapy team and is now effective. So today I will be reviewing with you the rationales behind sternal precaution, our new standardized approach, and the impact on patient outcomes. I'm going to review the algorithm we created with both streams of sternal precaution and introduce the next step from now. So sternal precaution were originally created to help to minimize wound complication. It was kind of the assumption that by restricting movement or activity, it would actually reduce the sternal instability and infection and then promote better healing. Well, then we kind of realize with time that strict sternal precaution can actually lead to decondition. It can have a loss of mobility. It could also have a longer return to function in cardiac and thoracic patient, which could lead to a longer stay in a hospital. And I remember as a young clinician helping patient out of bed, imagine a way that I could find a way to evaluate the force on a sternum while they were pushing with their elbows just a bit to get out of bed. And then, of course, you know, great mind thinks alike. In 2008, Parker and Al, they decided to do research and they looked at different force on the sternum while doing various tasks. And believe it or not, a cough exerts 60 pounds of force on the sternum. And then years went on, and Adam and Al in 2014 decided to do similar study, and they noticed that a sneeze would be quite the equivalent of a moderate intensity bench press, which would be about 90 pounds. So finally, a randomized trial in 2018 showed that actually standard restrictive sternal precaution and modified sternal precaution have similar effect in people after cardiac surgery in terms of physical recovery, pain, and quality of life. So we then decided as a team that we were going to conduct a pilot to see if it was feasible in our establishment. So our team felt that, you know, looking at an alternative, more flexible way to prescribe sternal precaution would have potential to improve quality in many aspects. So we then conducted a 3-month pilot here at the Heart Institute with certain patients, allowing them to use their arms for transfers, as long as their arms and elbow were close to their body. So following the move in the tube. So our pilot was conducted with a patient from one surgeon, Dr. Sorry, I'm just gonna move this here. Different slide, that's okay. So our pilot was conducted with only the patient of one surgeon having had median sternotomy. So of course, some patients were excluded from the pilot if they had to have rewiring or if they had cognition impairment, just because it was harder for them to follow commands, and morbidly obese. And so patient of Dr. Rubens were in the pilot, and we also had a control group, patient of Dr. Glinar. So our data actually were great. It shows that our patient had faster return to pre-op function and decrease the post-op length of stay from one group to the other. So modified sternal precaution had better results. And it also showed an improvement in post-op functional mobility at discharge. And less patient needed some gait aid actually prescribed after surgery. So those stats were just getting better and better. And as I mentioned in that previous clinical trial, the randomized study, well, also we found that there was no difference in the incidence of post-op site infection or dehiscence in both groups. So we then decided to go ahead and try to implement that here at the Heart Institute. So our new standardized approach was actually, of course, modeled by that study in Texas by Jenny Adams, Moving the Tube, but also we were inspired by an algorithm that was proposed by Callahan et al. From an article called Sternal Precaution, Is It Time for Change? So the model of sternal precaution is supported by all cardiac and thoracic surgeons at the Ottawa Hospital, and it's now standard practice. So by standardizing care, what we were hoping to impact and have, of course, even more impact in the future was to decrease the post-op length of stay for patient, improve their post-op functional mobility at discharge, and a faster return to their pre-op function. Also decreasing the incidence of sternal site incision and sternal dehiscence, hoping also for an earlier acceptance to our inpatient rehab program. Because in the past, if we had those strict sternal precaution, then there was a big delay for our patient to be able to participate in those programs. And of course, improving overall patient satisfaction and experience. So we decided to create an algorithm with two streams. So a modified sternal precaution and standard sternal precaution, which will be the term that is going to be used with family and patient. I will review the risk factor used to decide the level of risk for post-op complication. So primary risk factor means that if the patient has one of the following, well, they would be categorized into the high risk category. And of course, we don't use that terminology with the patient. So depending on their body habitus, if they're obese or large breasted, if they had sternal rewiring, or if there were any abnormal healing with the sternum post-op. Now, there's also secondary risk factors. So if the patient have two or more of these, then they would also be categorized into the high risk group. So with diabetes, cognition impairment, if they were a smoker, if there were any intra-op complication like lots of blood lost, or depending on the depending on the type of surgery. So if they use the thoracic memory graph, or if they reported any bone density issues, if they had previous cancer treatment or osteoporosis. So we then created this algorithm to help staff and patient to understand. Of course, this one was designed for staff because it's different than the one that is the patient will be exposed to, because we didn't want, of course, label patient into high risk and low risk group. But pre-op surgeon will be able to decide in which group the patient will fall into. So for example, if the surgeon decides to enroll the patient into the modified sternal precaution, that will mean that the patient will be instructed that they can use their arms for transfers. So as long as their arms and elbow are of course close to the body, like moving the tube. And they should still avoid lifting, pushing, or pulling more than 20 pounds with their arms. And that's for the next 6 weeks after surgery. And after 6 weeks of surgery, if there's no complication, they're healing okay, then they can then resume to normal unrestricted living. But after 6 weeks, if they're not healing properly, then they must continue on with those sternal precaution. And when I'm talking about normal healing, I'm talking about, if there's an improvement in terms of sternal pain, if there's no clicking, popping, or any instability of the sternum, no crepitus on palpitation, or no signs of local or systemic infection as well. Now, if the surgeon decide that the patient would be more suitable for standard sternal precaution, the same precaution we've been using for years because they're a bit more into the high risk group, then at that point, patient would be instructed not to push, pull, or lift more than 10 pounds with their arms for up to 8 weeks after surgery. And of course, they would continue on as well if ever the sternum was not healing right with the same precaution until they'd be seen here in the clinic if there were any issues. So we also created a kind of an add-on to our regular handout that we give to patient because this is so new. We do have a recovering from cardiac surgery booklet where the patient can follow all the instruction after their surgery. So we created one specific for modified sternal precaution with step-by-step what they're able to do and the progression. And they would also be aware of what normal healing is all about, and also a visual on how that they can move around, get out of bed the right way. So this add-on is put in by the physiotherapist because of course they're providing some individualized prescriptive like exercise program. So they already have to, you know, get the information to the patient. So that's part of their role. I do have a little extra part, so I'll take question at the end as well. Okay, so I would also like to share with you the post-op activity guideline that we encourage patients to follow, because I feel like a lot of lots of healthcare workers, they know that, you know, patients are seen by physiotherapists, but what are actually, what does the physiotherapy tell the patient? So to be honest, since the pandemic, so we had to come up with different ways to provide that information to patients. So all that education that we used to do with patient and family, so we kind of decided to create video, a French and an English video that the patient could view about the cardiac surgery physiotherapy discharge class. Because before we were hosting it on site a few days after the surgery before patient went home. So since the pandemic, of course, we had to find creative ideas. So we came up with, you know, bringing iPads to the patient room so that they can view it. Now, of course, if the patient have their own device, they could always use it, either an iPad or a tablet or a computer. And also with smartphone, they can now just scan a QR code because we have a poster in their room so that they can go directly into that webinar and see the video. So what the video is all about? Well, we do prescribe morning exercise routine to patient and a daily walking program. And so this is all also in the Recovering from Cardiac Surgery booklet that's available online, and each patient will get a copy before they go home, and the physio will handwrite exactly what type of walking program the patient needs to follow. And it's really designed to help the patient in their recovery, to build endurance, and also to prepare them for cardiac rehab. And we encourage them to follow that program until they start cardiac rehab, where they will kind of progress the exercise program we gave them according to their ability and goals. So here on that slide, you can have a bit of a visual of the type of exercise that we prescribe them. It's a morning routine that they have to do every day. Part of it is, it's kind of an overall general, because patient after a week stay in a hospital, they kind of feel like they've been hit by a bus and they complain of neck pain, back pain. So we have gentle stretching exercise for the neck. We have gentle rotation for the trunk. We also have some breathing exercise because also it's very important, of course. We have stretching exercise for the legs as well, because the more patient are walking, sometimes they'll feel some discomfort in their calf. And because we're prescribing them a walking program to follow, that's also very important. So in terms of the walking program, you know, exercise, it doesn't have to be very strenuous to have a big effect. So walking is one of the best exercise, and also in cardiac rehab, we encourage for all patients to walk. So the physiotherapist will base themselves on certain considerations. So if the patient had like a complicated hospital stay, that may have an impact. If they had post-op arrhythmias or high-grade arrhythmias, or if they're going home with controlled arrhythmias, that may change their walking program, depending on their left ventricle ejection fraction as well. Whether or not the patient would have like neuro, MSK, or respiratory issues prior to surgery, that also have an impact. And the type of exercise, or if they were active at all before surgery as well. So basically, we want patient to walk at least twice a day, morning and afternoon. In terms of intensity, we want them to start slow, and they should walk at a pace that they can have a light conversation with someone, that they're not too out of breath. And if they become symptomatic, well, they're instructed to take a little break. And they can also all refer to that booklet for specific. And if, you know, that booklet is misplaced, they can always call us back, because this is all part of our documentation. So we know exactly what the patient is supposed to be doing at home. And sometimes we do refer to that when they enter cardiac rehab. So patient also have a log in the booklet that they can fill out. And it's encouraged, because I think it's very helpful for both group, the patient and the healthcare team that is following the patient, so they can write down every day their progress. And that's also a great motivation tool that patient can use. Now, of course, patient are to expect to feel tired after surgery. It takes a few weeks until they regain their energy, and that's why we tell them to, you know, gradually increase your walking length instead of changing the intensity right away. But overall, by doing regular physical activity, it should help to lower blood pressure. It should help with endurance and fitness, of course. It should also help to improve their blood cholesterol and manage their weight and stress. So that's also very helpful for any patient. We do provide tips to patient. So like I mentioned, we want patients to be able to have light conversation when they're walking. Having a friend or a family member also helps with a motivation, because, you know, you can, you don't feel as lonely, and you can have personal goals. In terms of the terrain, while walking on a flat surface, of course, it's easier than going up a hill. But, you know, in reality, we just tell patient, if you do have to go up a hill, then you just have to slow down your pace or take more breaks. After a meal, it's always best for patient to wait half an hour to an hour, depending on the size of their meal, just because their heart will also be working for digestion. So we don't want them to feel tired too quickly, or, you know, they might not be as efficient. In terms of weather, of course, that will change when it comes closer to the summer. We tell patient, you know, if it's too hot and humid, make sure that you exercise perhaps when it's cooler in the day, or exercise indoors, because exercising could be outdoors, indoor, it doesn't matter as long as you do it. And of course, it changes in the winter. If it's very windy or cold or icy, it might be better for patient to stay in. Lots of tips about posture, because we feel like a lot of patients initially will be in pain and scared, so they tend to lean forward, have their shoulder forward rounded. So we want to work on posture, getting the shoulders back and relax, and making sure also that they do not cross their legs, just because there's a bit of tendency to create blood clots if we're having legs crossed because it's slowing down the circulation. And breathing. Breathing is very important. It should be steady in a relaxed manner. And of course, we're going to teach our patient to recognize some signs of overexertion and also what is not normal about, abnormal response to exercise. So if our patient complain of, feeling nauseous, dizzy, having a headache, or having chest discomfort or palpitation during their activity, we're going to tell them to stop, take a break. Of course, if it becomes an emergency and the symptoms are not decreasing after a while that they're resting, they're also instructed to call 911 as needed or go to the nearest emergency. And of course, they can always call our nursing coordinator, which has a 24-hour number access. So this is always an option as well. So I hope this was helpful for you to know a little bit more on what's prescribed to our patient post-op. And I would like to introduce Ruth Colton for the next presentation. She's our virtual monitoring coordinator.
Thanks so much, Tammy. It's actually Amy. I'm just going to start it off before Ruth comes up to present. So yeah, just to talk about a little bit about what's new in our surgical program, just to give everybody an update, especially if you do see our patients out there in the region and you do see our patient population. We already talked about this quite in depth in the previous presentation, but ERAS, of course, so the Enhanced Recovery After Cardiac Surgery Guidelines. So that's what's new. We have a whole ERAS multidisciplinary team here at the Heart Institute that's really directed by our quality team. So that's one of the big things that we're working on here to ensure that we're ticking all of those boxes for best practice guidelines for our patients. And again, with the different components, preoperative, intra, and postoperative. So all of the efforts that we have here at the Heart Institute, again, it involves the team. You won't have success unless we have the entire team involved. So that's really, really important. So Tammy kind of talked about it briefly about our patient education. So we did find a lot of our patient education classes and things like that were in person prior to the COVID, outbreak, pandemic. So it did make us have to become very creative. How are we going to make sure that our patients and their caregivers really get this information? So we developed different ways to deliver our patient education. So one of the new things that actually it's quite new is our webinar, Waiting for Cardiac Surgery. So this is a live class. Julie kind of touched on it a little bit, but it's a live class. It's open for patients and their caregivers. They can jump on every Thursday between 2 and 2:30. So it's for patients and their loved ones waiting for surgery. And it's very laid back. It's meant to be like a Q&A for patients at home, with those last minute questions, maybe just wanting a little bit more support from the team. So we have nursing there, dietitian, physiotherapy. One of the new things that we're actually adding on to this as well is a psychology support. So we have found that there's lots of patients and their caregivers at our home that are very overwhelmed, maybe with some extra anxiety, that need that extra support. So we're adding that onto our live Q&A. So we're very excited about that. Our patients, again, can just access this through our website. It's under tools and resources or under our calendar, and it's very easy to jump on. And also the nurses in the prehab area, like Julie, also present this to patients to use as well as a support. And of course, we also have our recovering from heart surgery discharge class. So it's live as well. So same thing, patients can sign on through the calendar. They can take a picture of the QR code. It brings them right into the class. It's every Monday, Wednesday, Friday. from 11 till 12. And so we're very happy to have this and offer this for our patients. If patients don't have access to the internet, or maybe they're not so savvy with using the internet, then they can also just call in using a telephone. 99.9% of our patients have telephones. So we just want to make sure that we make it open to all patients to be able to access our education. So I just wanted to kind of give you a brief update on that. Again, anyone from the audience is more than welcome to jump on to any of those education sessions. Even if you're a healthcare provider, we're more than happy with that for sure. So feel free to jump on. And if you're ever interested in any of our education resources, we're happy to share them as well. So you can reach out to me, no problem at all. So I'm going to move it on to something we're really, really excited about. It's our virtual telemonitoring program for our high-risk readmission patients after surgery. So it's for when they are discharged home. So I'm going to get Ruth to come up and talk to you guys a little bit about this new program that we have that we're very, very excited about.
Thank you, Amy. So as Amy said, we're very excited about our virtual telemonitoring program for patients at high risk of readmission or of surgical site infections post discharged from the hospital. So what is our program? Essentially, we have an overview of a virtual surgical transitions in care program, which encompasses as well our virtual telemonitoring program, which is what I will be speaking about. I and our team will get referrals from a variety of sources at time of discharge for the cardiac surgery patient. It can come from the care facilitator on the unit, the registered nurse taking care of the patient, physicians. Sometimes I get referrals as well from allied health, such as physiotherapy. And they'll refer a patient that they might be concerned about who might be at high risk of, as I said, readmission, vital sign concerns, or surgical site concerns. They'll refer the patient to me usually, hopefully 1 to 2 days prior to discharge, if not at time of discharge. And at that time, I will go and visit the patient in their room and have a conversation with them about if this is something that they're interested in participating with. What I'm able to provide the patients with is a tablet that is connected to a cell phone network, as well as the appropriate vital signs machines that I will also review shortly. And so daily, the patients at home and their family members will receive a questionnaire from us at a specific time. So usually it's between 7 and 9 in the morning. And on that questionnaire, the patient will be encouraged to report a variety of concerns. There's a section for surgical site concerns and another section for symptom concerns, such as shortness of breath, increase in pain, and unable to do their physical activity. And I receive this information through the cell phone system to my computer every day, and I'm able to look at every patient's information, including a selfie of their surgical site. So I very much emphasize that I don't really want to see patients' clothes, but I'd really like to see their surgical site. And so I do review their pictures every day. I follow up with the patients routinely. They, of course, have access to my phone number, and I collaborate very closely with the cardiac surgery advanced practice nurse and the physician team. And as appropriate or as required, if a phone intervention is not sufficient and we really need to see the patient in person, we will have the patients come to our ambulatory care center and see the cardiac surgery advanced practice nurse and a surgeon as well. At the time of their follow-up appointment, usually 6 to 8 weeks post-discharge, I'm able to send a good snapshot of the vital signs plus the most recent picture to the cardiac surgeon for their review, which of course helps them as they're not usually always seeing patients in person, and they're able to determine if the data that they look at is appropriate for discharge. Of course, we talk about what are our clinical inclusion criteria. And so what the Heart Institute and their allied health team did was looked at the reasons, the historical reasons for readmission, the reasons for postoperative complications, and what best practices or concerns were listed as well in the literature. So here you can see the 5 main reasons for readmission, and these are usually the inclusion criteria for referring to my program, our program. A weight of 2 kilos or above the preoperative weight of the patient prior to discharge, so the patient does remain fluid overloaded. The new onset of an arrhythmia that has not returned to a normal sinus rhythm prior to discharge, and the patient has been sent home without an anticoagulation prescription. The patient is a class 3 or 4 NYHA, heart failure or left ejection fraction less than or equal to 35%. A patient who is deemed at high risk for a surgical wound infection, and usually that of course consists of like an oozy, bleeding, sometimes kind of gunky looking surgical site. And then other reasons which we also monitor closely are patients at high risk for the readmissions, particularly diabetic with poor glycemic control, either preoperatively or immediately postoperatively in hospital. Postoperative delirium, of course, it needs to be, the program would need to be managed by the patient's caregiver, or as I said previously, an incision that is draining even slightly on discharge. What we have here is kind of an outline as to what I am able to monitor for each patient. So Bluetooth, of course, is a wonderful feature, and that connects our tablet to all of the vital sign machines that we have for the patient. So we're able to connect a weight scale, a thermometer, a blood pressure cuff, an oxygen saturation machine, and as well, and a pulse oximetry as well for the patient's heart rates. We're also able to ask patients to manually enter their glucose. Of course, we honor the system that the patient uses at home for their own self-glucose monitoring. And so we ask the patient to manually enter their daily glucose. So at the pre-designated time, of course, the patient will receive the questionnaire. It sounds a ding, like a cell phone ding on their tablet. They answer my questionnaire. They proceed to take the selfie of their surgical site, and then the tablet will prompt them into starting to transfer to me the information regarding the patient's weight, their blood pressure, their oxygen sat, their thermometer, and then finally their blood glucose. And all of that is pulled to me via the local cell phone network to my computer here at the Heart Institute. I wanted to outline here for you, of course, I acknowledge that it is a small snippet, but this is a big outline as to how our program works, who is involved in it, where our referrals come from, and kind of the pathway that you see here, which is what we're most proud of. I don't know if you guys can have the mouse, but the part that we're most proud of is, of course, we're bringing patients in for ambulatory care appointments, and thus preventing emergency room visits, family practitioner visits, and local walk-in clinics, and therefore allow the patient to be seen here at the Heart Institute in real person time. And then, of course, usually if there is a medication adjustment or some same-day testing that would be required, we're of course able to facilitate that as possible and as required. And then the patient would return back to continuing to send me their information on a daily basis. Here is a snapshot of some of our data that we have collected over the past, you'll see 2 separate quarters between July and September 2020 and July and September 2021. So you'll see here our rate of readmission in the first column, of course, was at 10.73%. And of course, our rate of surgical site infections was at 7.7%. Once we instituted the telemonitoring program, which happened in and around May, June of 2021, we noticed a significant decrease in our readmission rate down to half actually of what it had been in the previous year, to 5.12%. And of course, our surgical site infection rate also dropped drastically to 4.53%. The part that's very noticeable is that none of the patients who were enrolled on the telemonitoring program at the time were a part of these numbers. So that means that all our percentage related to readmission and surgical sites were patients who were not enrolled for a variety of reasons on our telemonitoring program. So we know with this snapshot that there is, of course, future potential to decrease our readmission rate, decrease our surgical site infection rate, and continue to do well with our patients. The patient feedback has been remarkable. They certainly appreciate the service and this availability. The one patient, of course, commented that it was a very proactive solution, and that it always gave the patient a sense of peace, that the Heart Institute was always available and didn't leave them dealing on their own. One other patient wrote in that they were very grateful for the technology. It always kept an eye on them, and they'll be forever grateful for the solution that we offered. And finally, this last patient was very hesitant at first when I approached her about enrolling in the program. And then, of course, at time of discharge, she was actually quite sad because she felt she had incorporated our daily check-ins into her usual routines. So, she'd wake up in the morning, do her daily care, do her telemonitoring setup for me, and then carry on with her day with breakfast, etc. And she felt that that component of her daily life was really going to be missing. And of course, I encouraged her to call us with any concerns. So I'll invite Amy up here right now with me, and we'll be able to show you the solution that we use briefly. But of course, because this is a regional chat that we're having today, I would encourage you in your communities, if you have patients that have been discharged from cardiac surgery here, of course you would have reached out with any concerns to our cardiac surgery APN or the surgeon's office. But if you think the patient can be monitored virtually, of course I'm happy to receive referrals as well from the outpatient population. I do receive on average 1 to 2 referrals from our clinic patients, and so please don't hesitate to reach out to us. Of course, the Heart Institute bunker knows how to find me, or you can send me a quick email, and we have ways to set patients up at quite a distance from here.
So just to add on, Ruth, to what you were saying, that one of the big things is we also wanted to give a big shout out to Erica McPhee, our VP here at the Heart Institute, because she's the one that is the reason for this program development and the great idea behind it all. So I always want to give a big shout out to Erica. And then yes, just like Ruth said, the first time that we started the program initiation, it began just with inpatients, but absolutely we now set up patients in the outpatient setting. So say we had a patient that maybe didn't screen as a high risk as an inpatient, maybe we've seen them in the clinic and they've now been deemed a high risk patient. We're able to set them up as an outpatient as well. And it also really does help with those patients who may live remotely, may not be able to get a ride to Ottawa. So we have many patients in the outside region, in rural areas as well. And we have ways of getting the device back to us if that's difficult for the patients. A lot of patients ask, or a lot of people ask, like, do you get your devices back? But we do. We get all our devices back from our patients, just so you're aware of that part. And yeah, we're just really, really excited about the program. And another question that we get a lot is what happens when the patient is discharged from the program? How does that work? And really, we kind of intertwine it into the surgical journey. So once they're discharged from the telemonitoring program, usually at that moment, they're ready for their cardiac rehab program. So that's kind of the journey, the transition for that patient after their heart surgery until they reach the cardiac rehab, and then they're transitioned from there. So with further ado, I did have someone just grabbing a tablet for us, but the way it works is the patients actually receive a tablet, just like an iPad kind of Samsung device tablet. It's closed, so obviously they can't Google or go on YouTube or do other things on their own at home, it's locked. So it's locked to our platform. And it's already has the access, the internet or the, what am I trying to say? The bell, yeah, the cell phone network. It's already embedded into it. So a patient doesn't need to have to use their own Wi-Fi. That's very important, especially for some people who may not have the means to have Wi-Fi at home. They just need to have some type of service towers. We haven't come across anybody who doesn't have service at the moment yet. So the way it works is patients will get the tablet. Again, the tablet will ask the patient questions based on our best practice guidelines that we already use. So it will ask some questions that screen for acute exacerbation for heart failure. It screens for risks for surgical site infection, et cetera, et cetera. We can see pictures of patients' incisions, which is really great. One of the things that's really interesting is we've seen numerous times where patients have answered, no, my incision does not look worse than yesterday. And it's funny because when we see the picture, it looks worse. So it's very interesting for that point of view in regards to the monitoring point for the high risk patient. So the way it works, if you guys can see this here, this is just like a little thermometer. So patients can just go ahead and take their temperature. That number would be sent by Bluetooth to the platform so the nurse can monitor it. We've got a weight scale, so it's really easy peasy. Literally, the patient just stands on it and it turns on and it will turn off on its own. And that number is Bluetooth to the platform. Blood pressure cuff, same thing. Literally, you just press start to turn it on. And we go over how to use the equipment with the patient before they go home. And we also give them supplemental information on how to use it. And then last but not least, our little pulse oximeter, you just throw it on the finger and the number will actually be sent to the platform. One of the cool things is also the platform's been set up for making it easier for triage or for managing in regards to the nurse. So it'll automatically set somebody as a red flag. For example, if their heart rate is out of a certain range or if their glucose is out of a certain range, and the program can be tailored based on what the patient needs. So not everybody needs everything. The program can be tailored based on the patient's needs. So that's one of the best parts of it as well. So I think at this moment, we can actually open it up to see if anybody has any questions. I'll invite Tammy to come back up here as well. And yeah, are there any questions at all for us today?
Sandra, anything from the chat to start?
Yeah, well, there's lots of great comments about how great this virtual telemonitoring program is. So wonderful job, ladies. There is some questions, I think, earlier for Tammy about these modified precautions. One of the questions was from Maurice. She asks, will modified precautions be clearly written on the cardiac rehab referral, standard versus modified sternal precautions?
Well, that's a really good question. Thank you for asking. And that's certainly something that we can work on with our triage coordinator and have our physiotherapist when they route that cardiac rehab referral to her to have specific on if it's sternal, the standard, or modified. And then our triage coordinator could just send that information to you. I have to mention as well, we're working on a small video presentation just to review all those aspects, the details about the two streams, and also information for the surgeon, cardiac and thoracic, on how to place that order in Epic, and then for allied health workers and nursing staff to where to go and see that that order as well and how to communicate it with the rest of the team. So that should be out very shortly. And please take my email in note so I can perhaps send that video to you as well.
Thanks so much, Tammy. I'm just going to ask another question for Amy and Ruth. These ones are about our virtual telehome monitoring. There's a few comments about the program itself. One comment is coming from Valerie about whether this program is also used to provide education, or is it strictly for monitoring, and how long are patients usually on this program for, the telehome monitoring?
That's a really great question, Valerie. Our program at the moment, we're using it actually as like a monitoring program. It does have the opportunity to push education if we wanted to. However, our patients already receive that education through our other means. So right now we're actually using it as a monitoring program. So no, we're not doing that because the patients already receive their education just like every other patient would. So that's not needed. And usually the patients are usually on the program for about 6 to 8 weeks, give or take. Some patients, if it's a little bit longer, it's usually our heart failure patients that stay on a little bit longer, but normally it's about 6 to 8 weeks. And again, they transition back to the cardiac rehab.
The other thing I'd reinforce is that the education, of course, is reinforced by the nurse who calls the patient. So things such as, diet or ambulation or wound care, et cetera. I'm sure you're all familiar with our stoplight tool and our gap tools and our booklets. So I definitely do reinforce all of that at the time of my call to the patients. And I usually call them routinely about once a week. And then, of course, I get some frequent callers in between there. And of course, if values are outside the norm, or if I need to repeat, especially oxygen saturation, I reinforce, of course, all the education at the time of the call.
Any other questions virtually, Sandra?
No, just a lot of great comments from our audience about how great this program is and our presentations. So thank you so much.
That's awesome, Sandra. Thank you. Any questions from the in-person audience, folks? Yes, Adelaide. So I'll just repeat the question. I'll let Amy come to the podium. The question is this program just for cardiac surgery patients? And what about other patient populations such as the heart failure? So let Amy answer.
Thanks so much, Annalie. That's a fantastic question. So yes, it's not only, so this specific program is specifically for cardiac surgery patients for telehome monitoring. It's actually quite new. There's not many places that are actually doing this for cardiac surgery patients. For heart failure patients, that's been here at the Heart Institute for years. In fact, I think it's been over even 20 years or so that we've had a program like that for our heart failure patients. So we do have that for our heart failure patients as well.
Thanks, Amy. Any other questions, folks? Okay, well, we're going to break for lunch and we should be back for 12:30 for our next presentation, moving focus a little bit to the state-of-the-art clinical approaches for smoking cessation, and then women's heart health after that, and cardiac rehab. So look forward to seeing you after lunch, folks. Thank you.